अनिल जी, hope I'm perfectly audible to all of you. Hope I'm perfectly audible to all of you. हाँ जी, चलो जी, चलो जी, चलो जी. MBBS 8981, welcome to the live stream and welcome all of you to the live stream. What about episode 3? But this is episode 3 only, just a little technical glitch by our side. So please don't mind about that glitch and we will try to rectify it as soon as possible. ठीक है? Chalo. So now I think this is the perfect time when we can start with the episode number 3. Okay, so you can see on my screen, this is episode number 3. Okay, so let's start with the lower limb and the dislocation and other stuff. Whatever is there, okay, for lower limb we will study. Okay, yes, yes, yes. Chalo, bache, chalo, chalo, chalo. Let's quickly start the session because I know yesterday's session was cancelled because of some reasons, but today's session also got delayed क्योंकि ठंड ज्यादा है ना, क्योंकि ठंड ज्यादा है इसलिए चलो. So let's quickly start with today's session, but before we start, let me just introduce you to what are the topics for today. Okay, so for today we will be discussing the lower limb trauma and dislocations, and in lower limb trauma we will have topic number 1, not 1 2 3 4, but yeah, I'm just listing the topics and we will see what we can take the early, पहले नंबर पे क्या टॉपिक लेना है, दूसरे पे क्या लेना है, वो हम देखेंगे, बट आपको लिस्ट बता देता हूँ. तो लोअर लिम्ब के अंदर में हम लोग एक पढ़ेंगे कॉक्सा वेरा. तो मैंने बहुत बार देखा है आप लोग कॉक्सा वेरा देखते हो, और कॉक्सा वेरा जब आप देखते हो तो आप महेश्वरी की किताब खोलते हो, उन्होंने एक पैराग्राफ जितना कॉक्सा वेरा दे रखा होता है, और उसी पैराग्राफ में आप उतना ही जो है एग्जाम में लिख करके आ जाते हो, विच इज एक्चुअली नॉट राइट. ठीक है, बिकॉज Coxa vara contains two very important topic. One is called as Perthes disease and other is called as SCFE, which are actually the most important causes of Coxa vara. महेश्वरी ने जो स्पेसिफिकली लिखा है दैट इज द कॉन्जेनाइटल कॉक्सा वेरा, कॉन्जेनाइटल कॉज ऑफ कॉक्सा वेरा. सो कॉक्सा वेरा हम एक पढ़ेंगे, उसके बाद हम लोग फ्रैक्चर्स डिस्कस करेंगे. इंट्राट्रोकेंटर फ्रैक्चर, ओके, इंट्राट्रोकेंट्रिक फ्रैक्चर, और रादर इंटरट्रोकेंट्रिक, intertrochanteric fracture, intertrochanteric fracture. Then other fracture is neck of femur fracture. Okay, neck of femur fracture. Then next we will discuss about the dislocation, posterior dislocation of hip. Okay, posterior dislocation of hip, because anterior dislocation of shoulder is important and posterior dislocation of hip is important. Then after that we will discuss about the difference between Thomas test and Thomas splint. Okay, Thomas test and Thomas splint, this is again a very important question that has been asked. So we will discuss this. Then we will discuss about the tourniquet. Okay, or about the, sorry, not the tourniquet, traction. Okay, then we will discuss about the traction, and in the end, if the time will permit, we will discuss some or the other MCQ topics as well, which can be asked in your university exams. Okay, which can be asked in your university exams. So this is the roughly roadmap. Okay, how we are going to proceed with today's session. Now my sincere request to all of you who all are viewing the lecture, जो भी लोग, जो भी बच्चे ये लेक्चर देख रहे हैं, आप सबसे मेरी एक सिंपल जनरल रिक्वेस्ट है बेटा जी, कि प्लीज प्लीज जो है एक काम करिए आप लोग, इसके अलावा यदि कोई टॉपिक लोअर लिम्ब से पढ़ना चाहते हैं ठीक है. If you want to read any other topic from lower limb, just let me know quickly. ठीक है. Just let me know quickly if you want to read any other topic in the lower limb. Okay, I'll just wait for you for your answers. Okay. Yeah. And if not, then we will start with today's session. Okay. आज हम क्वेश्चंस और जो भी हमारे एक्सरेज हैं उनको पढ़ने के बाद मतलब जब हम लोग थियरी पढ़ लेंगे उसके बाद हम लोग डिस्कस करेंगे अबाउट द एक्सरेज एंड अबाउट द क्या बोलते हैं उसको, जो भी तुम्हारी केस बेस्ड क्वेश्चंस हैं और वो सब, तो वो मैं आप लोगों को बताऊंगा. ठीक है. तो एक एक करके हम लोग टॉपिक स्टार्ट करते हैं. सबसे पहले बताओ क्या पढ़ना है टॉपिक, फिर उसी टॉपिक से हम लोग जो है स्टार्ट करेंगे. हाँ जी. चलो पहले हम लोग डिस्कस करते हैं अबाउट द इंटरट्रोकैंट्रिक फ्रैक्चर्स. ठीक है. इंटरट्रोकैंट्रिक फ्रैक्चर, एवास्कुलर नेक्रोसिस ऑफ फीमर हेड. अच्छा ठीक है. चलो ये टॉपिक भी ऐड कर देते हैं. एवीएन ऑफ हेड ऑफ फीमर, एवास्कुलर नेक्रोसिस ऑफ हेड ऑफ द फीमर. ठीक है बेटा. ओके. एवीएन ऑफ हेड ऑफ फीमर. ओके बच्चे. यस ठीक है. दिस टॉपिक ऑल्सो आई टेक, डोंट वरी. ठीक है बेटा. चलो ठीक है. पहले हम लोग आईटी फ्रैक्चर की बात करते हैं जिसको हम लोग इंटरट्रोकैंट्रिक फ्रैक्चर बोलते हैं. ठीक है. चलो बेटा, लेट्स स्टार्ट द टॉपिक विदाउट एनी फर्दर डिस्कशंस. इंटरट्रोकैंट्रिक फ्रैक्चर. ठीक है. चलो बच्चे, सो इन द इंटरट्रोकैंट्रिक फ्रैक्चर लेट मी जस्ट टेल यू हाउ वी आर गोइंग टू डिस्कस दिस. सबसे पहले हम लोग इसकी डेफिनेशन पढ़ेंगे. ठीक है. विल डिस्कस अबाउट द डेफिनेशन. आफ्टर डेफिनेशन आई विल टीच यू अबाउट द मैकेनिज्म. Okay, what is the mechanism of this fracture, intertrochanteric fracture. Then we'll discuss about the pathoanatomy. Okay, pathoanatomy we will discuss, and after pathoanatomy we'll discuss about the clinical feature, the diagnosis. Okay, and then the treatment modalities for IT fracture or intertrochanteric fracture, and then in the end we will discuss about the various complications related to your intertrochanteric fracture. Okay, intertrochanteric fracture. So this is going to be the way, this is going to be the tarika how we will discuss this. Okay, so this is how we are going to discuss the intertrochanteric fracture. Okay, just give me 1 minute beta log. नहीं बच्चे, from my end audio and video is perfectly fine. I think audio and video is fine from your end also. हाँ जी. हाँ ठीक है. चलो 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 चलो. So now we will discuss about the definition of intertrochanteric fracture. So as per the definition of IT fracture, it is the fracture of intertrochanteric region, fracture of intertrochanteric region, fracture of intertrochanteric region of proximal femur, fracture of intertrochanteric region of proximal femur, including either the greater trochanter, either the greater trochanter or lesser trochanter, either greater trochanter or lesser trochanter or both trochanters. Okay, either it will involve the greater trochanter or it will involve the lesser trochanter or it will involve both the trochanters. Okay, right. Now coming on to the mechanism. Okay, so let's now discuss about the mechanisms. So if we discuss about the mechanism, so in adult patient the mechanism of intertrochanteric fracture is different. In young patient, intertrochanteric fracture mechanism is different. Okay, so in elderly, it happens because of the sideway falls. Okay, I should say in elderly. So in elderly, it happens because of sidewise fall or sideways fall, and in young patient, what happens is violent trauma. Violent trauma. In elderly, sideways fall also is one of the cause, and other is trauma to greater trochanter. Trauma to greater trochanter. So either the trauma to greater trochanter, or in young patient it is the violent trauma. Okay, in the young patients it is the violent trauma, right? All right. So violent trauma, just like in a road traffic accident, right? So what is the pathoanatomy? Now, what do you mean by pathoanatomy? So pathoanatomy means the anatomical pathology. Anatomical pathology means which type of damage it is going to cause. So it is generally a displaced fracture. It is generally a displaced fracture or a comminuted fracture. Comminuted fracture. Okay, a displaced fracture can be there or a comminuted fracture can be there. Okay, and we have seen that the distal fragment, so there are two fragments, the proximal fragment, distal fragment. The distal fragment rides up. Okay, the distal fragment is going to ride up, so that the angle between so that the angle between femur neck so that the angle between the femoral neck and the shaft, okay, femoral neck and the shaft is reduced. Okay, so that the neck and the shaft angle is reduced. Okay, so that the neck angle and the shaft angle is going to get reduced. This was about the pathoanatomy. Coming on to clinical feature, I have already told you, whenever you are going to write any sort of fracture, please remember some things. Pain is common. Stiffness, okay, stiffness is a complication, so pain is something that is going to occur there. Swelling is going to be there. Decrease in the range of movement is going to be there. Decrease in range of movement is going to be there. Okay, so pain, where pain is going to be there, in the groin region. Swelling, where it is going to be there, in the hip region. Okay, inability to move the leg. Okay, so leg movement is something that is hampered or that is restricted. Leg movement is something that is hampered or that is restricted. And then tenderness over the greater trochanter. Tenderness, where tenderness? Tenderness over greater trochanter. So tenderness over the greater trochanter is going to be there. So this is about the clinical features of intertrochanteric fracture. Clinical features of intertrochanteric fracture. Coming on to the radiological diagnosis. So for diagnosis, what you are going to perform? For diagnosis, you will perform an X-ray. Okay. For diagnosis, what you will do? You will do an X-ray. And what you are going to see in that X-ray? For diagnosis, you will understand, you will see that, there will be, Hanji, there will be what? There will be either comminution comminution of medial cortex. So you have got medial cortex, you have got lateral cortex, because if I just draw the anatomy of your femur bone, then you will have the medial cortex and you will have the lateral cortex. So there will be comminution of the medial cortex, because it's an intertrochanteric fracture and the fracture line is like this. So there is comminution of the molar medial cortex. Comminution is something that is seen more. Okay, medial cortex, and that's why avulsion of lesser trochanter is also sometimes and some other times are seen. Avulsion of lesser trochanter. Okay, and then extension can also be seen. Extension of fracture in the subtrochanteric region. Okay, extension of fracture in the subtrochanteric region has also been seen. Now whatever I've written, please remember, this indicates an unstable fracture. This entire indicates an unstable fracture, and moreover, an unstable fracture, it also indicates that it is having a poor prognosis. So if on X-ray you get to find the comminution, you get to find the avulsion and extension, then you have to understand it's an unstable fracture. It is having a poor prognosis. Unstable fracture with a poor prognosis. Okay. Now, coming on to the last part of intertrochanteric fracture, last second part, that is the treatment. Now, what is important in treatment? See, in treatment, so why do we treat? Okay, or what is the goal? Okay, what is the goal of the treatment? The goal, the primary goal of the treatment is to maintain. Understand, the primary goal of the treatment is to maintain what? Is to maintain a normal femoral neck shaft angle. Okay, so to maintain a normal femoral neck shaft angle. To maintain a, no, a femoral neck shaft angle. Okay, this is very important. So why I have written this? It is just to emphasize that this IT fractures are not a problem at all. Understand this. IT fracture is not a problem at all. IT fracture is a easily easily unitable, I should say, easily what I should say, unitable. Okay, or easily unite. Okay, IT fractures easily unite. Just what is the goal of the treatment is to maintain the femoral neck shaft angle. Okay, just to maintain the femoral neck shaft angle. Okay, acha. Now how will you treat? So we have got a conservative technique. Okay, we have got a conservative method of treatment. So what is the conservative method of treatment? The conservative method is Russell's traction. So first important part is Russell's traction. Okay, Russell's traction. And other second important thing is skeletal traction. Russell's traction and skeletal traction. Now, what is important in skeletal traction? Just understand that skeletal traction is done in Thomas splint. Okay, skeletal traction is done in Thomas splint. So, skeletal traction is performed, skeletal traction is done in Thomas splint. Okay, next, what is important in conservative? So, just remember we give prolonged bed rest. Okay, so we give prolonged bed rest. Okay, prolonged bed rest is something that is told to the patient. And how much? So remember, IT fracture. IT fracture are three words. So approximately 3 to 4 months of bed rest is something that we generally ask the patients. Okay, right? Okay. Now, just remember that because it's a prolonged bed rest, what we are giving. So this prolonged bed rest can cause complications. Okay, can cause complications such as bed sores. Okay, it can cause bed sores, it can cause the pneumonia. Okay, so these are something which are the complications. Okay, so this is again related to recumbency. Okay, so what is the position of the patient? Recumbency complications we call them as. So these are really important. Bed sores and pneumonia, something which can occur. Okay, so this is important about the conservative methods. And after conservative methods, the next important thing is operative methods. Okay, operative methods. Okay, so this is really important. Okay, so what is operative methods? So in operative methods we opt for open reduction, internal fixation. Open reduction plus internal fixation. Open reduction plus external fixation. Okay, okay, चलिए मुझे बताइए, इन ऑर्डर टू डू द इंटरनल फिक्सेशन, अब जितने भी लोग हमारे साथ में देख रहे हैं, 4 or 5 people, टेल मी व्हाट इज द मोस्ट कॉमन, ओके, टेल मी what is the most common device used for internal fixation? What is the most common device used for internal fixation? It is Hanji. Most common device used for internal fixation is, quickly tell me, Bacha Party. What is the most common device used? So it is It is dynamic hip screw. It is dynamic hip screw. बेटा plates also are used, ऐसी बात नहीं है, but the most common if they ask, it's dynamic hip screw. Okay, then other things, of course, you can write the nails. Which nail is used for IT fracture fixation? Ender's nail. Okay, which nail is used? It is Ender's nail. Okay, which nail is this? This is Ender's nail. Then gamma nail. Okay, Ender's nail, gamma nail, and of course PFN. PFN is really important. PFN is asked in your MCQ exams also. PFN is very important Viva question as well. PFN, proximal femoral nail. Okay, proximal femoral nail. This is really important question asked. Proximal femoral nail. Okay, proximal femoral nail. Okay, so this is about the most common technique, that is the internal fixation. Although external fixation is also something which is used. Okay, we also do external fixation as well. So what do we do in external fixation बच्चे? So in external fixation we do, हाँ जी, किसमें करते हो? Yes, so we do in the patients with bed sores. Okay, so when to do external fixation? External fixation is done in patient with bed sores. Okay, bed sores, or some people who are unfit for, okay, so if patient is unfit for surgery, in unfit for major surgery, so in both these cases you do what? You do external fixation. Okay, you do what? External fixation. Okay, so this is the I mean, in short, I've tried to explain you about the operative methods and all. Okay, so coming on to, so after external fixation, let's understand about the complications. Okay, so after external fixation, let's understand about the complications. So what are the different complications? Okay, yes, quickly tell me, what are the complications of IT fracture? Hanji, complications of IT fracture. Very important, malunion. Okay, this is a very important MCQ point as well. Malunion is the most important, most important complication, malunion. Okay, and this malunion gives rise to what? It gives rise to coxa vera. Very good MBBS 8981 malunion, and it gives rise to coxa vera. Now in very first class I told you, that vera, what does that vera means? Distal bone is going to go inside. Okay, distal bone is going to go inside. Okay, so what is coxa vera? Hanji, coxa vera. Hanji, what do you mean by coxa vera? Distal bone is going to go inside. Okay, distal bone is going to go inside. That means coxa means hip, so distal bone is femur. So normally if it is like this, then it will be going like this. Okay, this is going to go inside. So this is the malunion, this is the coxa vera which is going to happen. Okay, okay. So what is the treatment of this condition of malunion? Hanji, what is the treatment of this coxa vera malunion? We do IT osteotomy. Okay, IT osteotomy. So IT osteotomy means intertrochanteric osteotomy is something which is done, but generally we avoid this. We avoid this in elderly patient. Okay, IT osteotomy is avoided in elderly patients. Okay, avoided in elderly patients. Okay, yeah. After that, coming on to the next one, osteoarthritis. So one is malunion and other is called as osteoarthritis. Okay, so after malunion, let's understand about the osteoarthritis. So osteoarthritis is again important. So if now osteoarthritis can be in early stages or can be in late stages. So if it is occurring in the early stage, then we call it, then we have to perform what? We have to perform physiotherapy. And if it is occurring in the late stages, then we have to see if the patient is a young patient or the patient is an old patient. So if the patient is young patient, then we do trochanteric osteotomy. Okay, we do what? Trochanteric osteotomy. Trochanteric osteotomy. Okay, and in old patient we do total hip replacement if there is osteoarthritis. Okay, we do what? Total hip replacement. So coming on to some more important points, let me just add the important points over here only. So so in the clinical feature only, let's understand what is the age, So age, generally the age is 60 years. So after 60 years this is going to happen. And if somebody asks me about sex, so remember male is more commonly involved than the female. Okay, it is more commonly involved than the female. Okay, and so I've told you that leg movements are gone. Okay, so movement is something which is not possible. Okay, so pain, swelling, tenderness, and one more, ecchymosis. Yes, pain, swelling, tenderness, ecchymosis, everything is going to be there. Okay, so one important thing is external rotation deformity. So this is a very important point. So if somebody asks you about the external rotation deformity, so just remember external rotation deformity is more than 45 degrees, more than 45 degrees. Okay, more than 45 degrees. And similarly, more than 1 inch is the shortening of limb. So shortening of limb is also more than 1 inch. Okay, yes, more than 1 inch. That is really, really important for intertrochanteric fracture. Okay, for what? For intertrochanteric fracture. So understand, I have told you about the intertrochanteric fracture now. Okay, then we will discuss about neck of femur fracture. Then we will discuss about their difference, and then I will add some or the other more points as well. And then we will move on to the case-based discussion, and then I will show you the radiological images as well. Okay, radiological images as well. So this is about the Chutusa topic, that is intertrochanteric fracture. And let's discuss about the next topic, that is fracture neck of femur fracture. Okay, neck of femur fracture, which is a little big topic. Okay, so fracture neck of femur. इतनी गंदी राइटिंग तो नहीं है मेरी, आई डोंट नो ये पहचानता क्यों नहीं है। ठीक है, चलो, नाउ वी विल डिस्कस अबाउट द फ्रैक्चर नेक ऑफ फीमर। ठीक है, सो इन फ्रैक्चर नेक ऑफ फीमर, आई होप बच्चों आप लोगों को जितना भी मैं समझा रहा हूँ आप लोगों को समझ में आ रहा है। ठीक है, कमिंग ऑन टू द फ्रैक्चर नेक ऑफ फीमर, सो फर्स्ट ऑफ ऑल एज द नेम सजेस्ट्स, we will discuss a little about the definition of fracture neck of femur, then we will discuss about the पैथोएनाटमी। पैथोएनाटमी का मतलब होता है कि ये फ्रैक्चर जो है वो, ठीक है, उसकी एनाटॉमी क्या है, वो डिस्प्लेस्ड है, नहीं है, क्या है, क्या नहीं। सो वी विल डिस्कस दैट। आफ्टर दैट वी विल डिस्कस अबाउट द क्लासिफिकेशन। ओके, देन वी विल डिस्कस अबाउट द क्लासिफिकेशन। ठीक है, सो पैथोएनाटमी के बाद में हम लोग डिस्कस करेंगे अबाउट देयर क्लासिफिकेशन एंड देन द other parts, because classification is also various classification. We'll discuss only the important ones. Then we will discuss about the mechanism of injury, the clinical features, the diagnosis, the radiological diagnosis or radiology, and in the end we will move on to the treatment part. Okay, we will move on to the treatment part. So coming on to the very first thing, that is the definition. So as the name suggests, the it is the neck of femur fracture, or I should say intracapsular fracture of the femur neck. Okay, intracapsular. This word is really, really important. Intracapsular fracture of femur neck. ठीक है, so neck of femur fracture है, सबको पता है, but this is intracapsular fracture of femur neck. Okay, intracapsular fracture of the femur neck, because extracapsular fractures are something which are called as intertrochanteric fracture. Intertrochanteric fracture. So any fracture which is happening outside the capsule, it is called as intertrochanteric fracture. Okay, intertrochanteric fracture. Coming on to the pathoanatomy. So here most fragments are displaced. Okay, most fractures, sorry, are displaced fractures. Okay, displaced fractures are most common. Okay, and we have seen that the distal fragment, okay, distal fragment is externally rotated. Okay, distal fragment is two things, externally rotated also, externally rotated, as well as it is going to migrate proximally. It is proximally migrated and externally rotated, proximally migrated as well as externally rotated. This is really, really important thing. Okay, yes, and remember this, that displacement is less marked. Why displacement is less marked? Because of capsule. Okay, the Displacement is less marked. Why? Because of capsule of the hip joint is attached to the distal fragment, because capsule of hip joint is attached to the, okay, attachment to what? Attachment to your hip joint. Okay, it is attached to your hip joint. Okay, no, it is attached to the distal fragment. Yes, it is attached to the distal fragment, right? Coming on to the classification now. Okay, so let's understand about the classification. So what is important in classification? There are three classifications and really important classifications. Okay, so I'll make a box for you about these classification. First classification is anatomical classification. Then you have got Powell's classification, and in the end we will have a Gardner's classification. Okay, Gardner's classification. So anatomical classification, Powell's classification, and in the end we will have a Gardner's classification. So what is important in anatomical classification? So please remember, in anatomical classification you have three parts: subcapital, transcervical, basal. Subcapital, transcervical, and basal. ओके, बेसल. सो एनाटॉमिकल, देखो आप खुद से ही समझ जाओगे एक ही मिनट के अंदर में कि सब कैपिटल का क्या मतलब है, सर के नीचे, ट्रांस सर्वाइकल गर्दन के आर पार, एंड बेसल मतलब एट द बेस ऑफ द नेक. सो इफ आई जस्ट ड्रॉ अ वेरी गुड डायग्राम, इफ आई जस्ट ट्राई टू ड्रॉ अ वेरी good diagram, which I am not good at drawing the diagrams, but still okay. So अगर मैं ये बनाऊं तो देखो, ट्रांस सर्वाइकल का मतलब होता है नेक के आर पार, बेजल होता है इसके नीचे. ठीक है, बेजल कहाँ होगा? बेजल होगा इसके नीचे यहाँ पर. ये होगा आपका ट्रांस सर्वाइकल. और पहला क्या था आपका? द फर्स्ट वन वाज सब कैपिटल, जस्ट बिलो द हेड. सो सब कैपिटल मींस फ्रैक्चर इज जस्ट बिलो द हेad. Okay, so if the fracture is just below the head region, it is called as subcapital. Transcervical means across the, ठीक है, in the middle of the neck. So transcervical is in the middle of the neck region. Okay, and what about basal? So basal is at the base of neck. So fracture is at the base of neck region. Okay, so sub capital, transcervical, and basal. Coming on to Powell's. Now coming on to Powell's में क्या होगा? So this is the classification which has got type 1, type 2, and type 3. Type 1, type 2, type 3, where it is going to measure the angle of inclination of fracture in relation to the horizontal plane. So for example, if this is the fracture, okay, wait, this is my bone, and for example this is the fracture. So what is the inclination of fracture line with the horizontal plane is something which is called as Powell's angle. So what do you mean by Powell's angle? First of all, this is important. So PAU, Powell's angle. Okay, what is Powell's angle? So Powell's angle is the angle between, okay, angle between, or angle of inclination between the fracture line, between the fracture line and between the fracture line and the horizontal plane. Okay, so it is the angle of inclination between the fracture line and the horizontal plane. Fracture line and the horizontal plane. So if this angle is 30 degrees, if this angle is 50 degrees, and if this angle is 70 degrees, then it is the Powell's classification. It is the Powell's classification. Okay, type 1, type 2, and type 3. Similarly, Gardner's classification is also going to have type 1, type 2, type 3. So what is important in Gardner's classification? Gardner's is based on degree of displacement of fracture. Okay, so Gardner's classification is something which is based on degree of displacement of fracture. Degree of displacement of fracture. Okay, degree of displacement of fracture. Okay, degree of displacement of fracture. So what happens? Okay, in garden is a little big garden, so you have got 1, 2, 3 as well as 4. Okay, big garden. So 4 means what? 4 means, okay, now first means fracture is incomplete. So this one resembles with I, and I tells you that this is a incomplete fracture. Okay, the one is resembling with the letter I, and this I stands for that this is an incomplete fracture. Okay, incomplete fracture. And you can remember my name. My name is Parv Luthra, P and L. So what is P and L? And I'm always first class. Okay, okay. I'm always first class. So what you have to understand from this, that head is tilted in posterolateral condition. Okay, head of the femur is tilted in posterolateral. Okay, posterolateral position, head is tilted. So posterolateral tilting of head of femur. Posterolateral tilting of head of femur. Posterolateral tilting of head of femur is going to be there. Okay, then the angle is going to be obtuse. Understand, there is obtuse angle. Okay, there is obtuse, oh shit, sorry, there is an obtuse angle. Where obtuse angle? There is an obtuse angle laterally at the trabecular stream. So obtuse angle laterally at trabecular stream. Okay, and that's why it is called as what? Again, I is coming impacted or abducted fracture. Impacted or abducted fracture. So remember, this A also is the word which comes first in the ABCD, and I तो है ही है first का. So impacted fracture बोलते हो इसको, नहीं तो abducted fracture बोलते हो. It is an impacted fracture, or it is also called as abducted fracture. Impacted fracture or abducted fracture. Coming on to second part. So second part is fracture is going to be complete. So it's a complete fracture because initially it was incomplete. Now it is complete fracture, and with the complete fracture it is undisplaced fracture. Undisplaced fracture. Okay, so there is break in the trabecular stream. Okay, there is break. So understand, break. अब ये याद रखो ना, second letter क्या होता है अल्फाबेट्स का? B होता है. So there is B for break. Okay, so break in what? Break in trabecular stream with the little angulation. Break in trabecular stream with little angulation. With little angulation. ओके, चलो, किसने बताया था सेकंड के बारे में? कंप्लीट अनडिस्प्लेस्ड, एमबीबीएस 8981. वेरी गुड बेटा, सो प्राउड ऑफ यू. यू आर टेलिंग ऑल द आंसर्स वेरी वेरी करेक्ट, एंड गॉड ब्लेस यू. इसी तरीके से अगर आप हमारे साथ पढ़ते रहोगे कंसिस्टेंसी से, यू विल बी एबल टू फिनिश ऑर्थोपेडिक्स एंड स्कोर वेरी गुड मार्क्स इन ऑर्थो. ठीक है, सो दिस इज माय प्रॉमिस टू यू गाइस. पक्का डिस्टिंक्शन आएगा, डोंट वरी एट ऑल. ठीक है, कमिंग ऑन टू द स्टेज 3. सो व्हाट इज देयर इन स्टेज 3? Stage 3 is also complete, but it is displaced. Okay, it is complete. Yes, we know, everybody knows that stage 3 is going to be complete because only stage 1 is incomplete. Rest everyone is complete. And जो second था, that was undisplaced. देखो ना, one word, displaced second word, so undisplaced. दो words आ रहे हैं, so that means belongs to two. Whereas in 3 it is going to be what? It is going to be complete. It is going to be displaced. Complete as well as displaced. And what happens is that the distal fragment, okay, that the distal fragment कौन सा होता है? ये वाला. Then the distal fragment is going to rotate externally and causes internal rotation of head. Okay, so there will be external rotation of distal fragment, and that causes what? That causes internal rotation of head. Okay, internal rotation of head. Okay, external rotation of distal fragment and internal rotation of your head. Internal rotation of head is going to be there. Okay, and one important thing is that the alignment. Okay, यहाँ लिखेंगे that the alignment between trabecular stream. Okay, alignment between the trabecular stream and acetabulum is gone. Okay, alignment between the acetabulum and the trabecular stream is gone. Okay, it is gone. Or trabecular stream के बजाय trabecular of head region and acetabulum is also gone. Okay, and what about stage 4? Yes, what about stage 4? Stage 4 is having your complete and displaced fracture. Complete fracture, displaced fracture. Okay, complete fracture and displaced fracture. ट्रेबिकुलर स्ट्रीम, व्हाट इज ट्रेबिकुलर स्ट्रीम? बेटा ट्रेबिकुलर स्ट्रीम इज द ट्रेबिकुले, ट्रेबिकुले पता होगा आपको, सॉफ्ट बोन, हार्ड बोन, वही होता है, ठीक है। चलो, coming on to what is the mechanism of injury in this. So let's understand about the mechanism of injury in neck of femur fracture, ठीक है। mechanism of injury in neck of femur fracture, very important mechanism. Trivial fall in elderly and severe trauma, okay, severe trauma in adults, sorry, in young patient, okay, in young patient, whereas in elder patients it is nothing but severe trivial fall. It is the trivial fall in case of elderly patients, ठीक है। बड़े बुजुर्गों में गिरने की बहुत आदत है, ट्रिवियल फॉल इन एडल्टली पेशेंट्स, ठीक है। देखो, एक चीज है आपको समझना चाहिए, दैट एल्डरली पेशेंट्स हैव गॉट ऑस्टियोपोरोसिस, ठीक है। सो ऑस्टियोपोरोसिस जो होता है वो एल्डरली पेशेंट्स में बहुत ज्यादा होता है, इसीलिए ऑस्टियोपोरोसिस इज थॉट टू बी अ कॉन्ट्रीब्यूटरी, आई शुड से a significant contributory factor, a significant contributory factor, okay, in the in causing the neck of femur fracture. So what is going to be the clinical feature now? So please understand, whatever we discussed in the IT fracture, almost similar things are going to be there here also. So there will be pain, and where will be the pain? Pain in the groin region, okay, pain will be the groin region. So limb movements are going to be decreased, okay. Then weight bearing, yes, weight bearing is also going to be decreased, okay. There is going to be decreased weight bearing is going to be there. There is going to be your slight swelling, okay, there is going to be slightly swelling also. Then patient will have what? Hanji, will have what? Acha, now can patient walk? Next important question. Can the patient walk? Chalo, batao, can the patient walk or not? Hi, Dr. Anjali. Good evening. So, can the patient walk of neck of femur fracture? Neck of femur fracture if the fragments are impacted. Understand? If the fragments are impacted, yes, patient can come. Okay. Yes, patient can come walking as well, okay. Yeah, generally patient can't walk, but yes, can come walking as well, okay. So what will you see on examination? So whenever you will go for the examination of the patient, so during the examination of the patient, you will be able to see external rotation, okay. Tenderness is of course going to be there, beta. External rotation. Okay, I've told you now that there will be external rotation of the distal fragment. So there will be external rotation of the leg, and that is why the patella will be facing outwards. Patella will be facing where? The patella will be facing outwards. Okay, there will be shortening of leg, exactly. There will be shortening of leg, that will be seen for sure. Yes, there will be tenderness, as one of the kids says, tenderness of the groin region, or tenderness I should say in the groin region. Okay, okay, then what else? Yes, actively straight leg stretching. Actively straight leg stretching is something which is impossible. Actively straight leg stretching is something which is not possible, which is something impossible. So that is the examination findings, okay. Now coming on to the x-ray, okay. Tell me in the comment section if is it necessary to perform the x-ray of both legs or not. So x-ray both legs is required or not? Hanji, x-rays is required for both legs or not? Yes, x-rays of both legs are required. Why x-ray of both legs are required? Because I have told you that osteoporosis is a very much contributory factor for neck of femur fracture. Okay, it's a contributory fracture of neck of femur factor of contributory factor of neck of femur fracture. Okay, so coming on to the important features which I always teach you. One is the break in the medial cortex. Okay, break in the medial cortex of neck. Okay, break in the medial cortex of the neck. Then external rotation of the femur bone. Okay, external rotation of the femur bone. Then overriding of the greater trochanter. ठीक है, overriding of the greater trochanter. Then break in the trabeculae, break in the trabeculae, and then break in the Shenton's line also. Hanji, break in the Shenton's arc or Shenton's line also. What do you mean by Shenton's arc or Shenton's line? Hanji, what do you mean by Shenton's arc or Shenton's line? So I think I have drawn the picture over here. हाँ, तो देखो ये जो होता है, this is the arc of the neck of femur. Okay, and here you will have the pelvic bone. Okay, here you will have the pelvic bone. So ये जो एक arc बन रही है इसको आप Shenton's arc बोलते हो, and this Shenton's arc is going to break if there will be break in the neck of femur fracture. So Shenton's arc again is an important thing which we have to look for. Okay, coming on to the management part. Okay, coming on to the management part of intertrochanteric fracture. So in management part, just please remember this fracture is termed as unsolved fracture. Okay, so this fracture is called as unsolved fracture. Can you tell me why it is called as unsolved fracture? Why it is called as unsolved fracture? Because it is associated with a large number of complications. Okay, because it is associated with a large number of complications. Okay, that is why why there are large number of there are large number of complications, and that is why the treatment of this fracture is difficult. The treatment of this fracture is difficult, and further, why treatment of fracture of this fracture is difficult? Because there is blood supply break. Okay, so the blood supply, understand, the blood supply of proximal fragment is broken. Okay, the blood supply of proximal fragment is gone, is hampered. So the blood supply of the proximal fragment is going to be hampered, it is going to be cut. Okay, and second important thing is that uh, sometimes we have seen that the proximal fragment is too small. Okay, so if the proximal fragment is too small, then it is difficult. Okay, then it becomes difficult to maintain the unity. Okay, it is difficult to maintain the unity between the fragments. Okay, so fragments can't be united properly because sometimes we have seen that the proximal fragment is too small. Okay, the proximal fragment is too small. Okay, so these are generally the two important problems. Okay, so what do we do in this case? How do we treat the case? So remember two important things. Of course, like these are not two new things for you, and very simple, easy things. Either you will do a closed reduction or you will do an open reduction. Okay, so both the reductions are done in these patients. Closed reduction is also done, and the open reduction is also done. Okay, open reduction internal fixation. Okay, it's something that which is commonly done. Now, what one thing you have to understand, that conservative management is given, but conservative management ऐसा नहीं है कि देते नहीं है, it is given but is not modality of choice. Okay, so we can't just do the conservative management and run. No, these things we cannot do. Okay, so what do we do? Okay, internal fixation. How do we internally fix this? So most commonly, how do we do this? Anji, quickly tell me, how do we do? Yes, we do dynamic hip screw. Yes, dynamic hip screw is something that we can use. Okay, we can use the novel spins also, knowledge spin, what we call it as. Hanji, or we can use the Murray spin as well if it is in children. Okay, Moore spin or Murray spin, that is used in children. But what is most common? No, but DHS is not most common. Most common is your multiple cancellous screws. Okay, so we use multiple cancellous screws because it's a osteoporotic bone. Okay, multiple cancellous screws are given because it's an the osteoporotic bone. Okay, osteoporotic bone. So let me just make a chart. I mean, this is not my own chart. This chart has been given in Maheshwari, so I'm just trying to give you this chart. I don't know about the edition of now, but yeah, in old editions this was given fracture neck of femur. So you have to check if it is a, you know, if it is a displaced fracture or if it is a undisplaced fracture. So if it's an undisplaced fracture or it is an impacted, sometimes we have seen that it is impacted also. So if it is impacted and if it is undisplaced, then we will use conservative methods. Okay, then we will use what? Conservative methods. But I have told you that, you know, conservative methods we use the Thomas splint also. Okay, but if it is impacted, but yeah, since I've told you that it's practically more associated with some complications, so we always prefer the operative modality. And one more important thing is that we can use the uh, multiple screws. Okay, multiple screws as well. Coming on to displaced fracture, then we have to check if the female, okay, then you have to check if the female, now mind you, this table is really important for your NEET as well, for your FMGE class as well, and for your INI-CET. So very, very important. Okay, very important. So now we'll check if it's displaced. So we have to check if it is a displaced, then what is the age? So if it is more than 60 years, then one thing. If it is less than 60 years, then another thing. So if it is more than 60 years, believe me, we will have to do prosthetic replacement. Okay, we have to put what? Prosthetic replacement, prosthesis is also a very important topic and we'll discuss in near future, but prosthesis important topic. So what we have to understand in prosthesis, that if the other hip is normal or not. So if the other hip is normal, we go for hemiarthroplasty. We go for what? Hemiarthroplasty. Okay, because so that, you know, the weight will be shared on both the hips. But if the other hip is having arthritis, okay, so you should understand that sorry, not other hip, otherwise. Okay, so if otherwise it is normal and not. So if it is normal, then we will do, if the hip is normal, we'll do hemiarthroplasty. If it is having arthritis already, okay, if it is having arthritis already, just understand we will do what? We will do what? हाँ जी, क्या करेंगे हम लोग? टोटल हिप रिप्लेसमेंट, क्योंकि आर्थराइटिस है. बट यदि मान लीजिए वो लेस देन 60 ईयर्स का है, तो अगर वो लेस देन 60 साल का बच्चा है, बुजुर्ग है, जो भी है, देन वी हैव टू अंडरस्टैंड दैट इनके अंदर में हमें प्रोस्थेसिस वगैरह नहीं भी लगाया तो भी चल जाएगा एंड वी कैन गो फॉर क्लोज्ड रिडक्शन. क्यों ज्यादा चीराफाड़ी करनी है? लेट्स डू क्लोज रिडक्शन. लेट्स डू क्लोज्ड रिडक्शन, क्लोज रिडक्शन. तो क्लोज रिडक्शन जब हम लोग करते हैं तो हम देखते हैं कि रिडक्शन पॉसिबल है क्लोज रिडक्शन या नहीं. If it is possible, very good. Then what we have to do, if it's possible, then we will do multiple screw fixation. Okay, we will do what? We will do multiple screw fixation if the closed reduction is possible, and the other thing is where reduction is not possible. So if the reduction is not possible, then we have to do open reduction with screw fixation. Open reduction with screw fixation. Okay, with screw fixation. ठीक है, तो देखो भाई, सीधी सी बात मैं आप लोगों को बताता हूँ कि फ्रैक्चर नेक ऑफ फीमर जहां पर भी आता है, ठीक है, नेक नेक, ठीक है, वो क्या ऐसे होता है ना, पुष्पा, कटेगा नहीं साला, मतलब हर जगह पे काटने की जरूरत नहीं है. ठीक है, यू आर नॉट सपोज टू डू द ओपन रिडक्शन. वी कैन फर्स्ट ऑफ ऑल गो फॉर द कंजर्वेटिव मेथड्स, then we can go for closed reduction, and then we have to check if prosthesis is required. So if the closed reduction is, see closed reduction चाहिए, देख लो पॉसिबल है, मल्टीपल स्क्रूज लगा दो, नहीं है ओपन करके स्क्रू लगा दो, क्लोज करके स्क्रू लगा दो, ओपन करके स्क्रू लगा दो, खत्म। ठीक है, नहीं याद रहता ऐसे याद रख लो कि जो सी आर होता है वही तुम्हारा सी एस बनता है। ठीक है, सी आर होता है क्लोज रिडक्शन, सी एस मतलब कल्चरल सेक्रेटरी बोलते थे हमारी स्टूडेंट काउंसिल में। ओके, एंड सी एस इज रियली इंपॉर्टेंट, एस बोले तो स्क्रू लगा दो। ठीक है, और उसके बाद इफ क्लोज रिडक्शन इज नॉट पॉसिबल, ओपन रिडक्शन करके स्क्रू लगा दो, बात खत्म। और 60 साल से अगर ज्यादा बुजुर्ग है, बहुत बुजुर्ग है, तो हमें प्रोस्थेसिस लगाना पड़ेगा। नॉर्मल हिप है, हेमी आर्थ्रोप्लास्टी कर दो। ठीक है, आर्थराइटिस है, टोटल हिप रिप्लेसमेंट कर दो, सिंपल सी बात। देखो अदरवाइज नॉर्मल हिप है, एच से हिप होता है बच्चे, एच से हेमी आर्थ्रोप्लास्टी होती है। ठीक है, उसके बाद अपन बात करते हैं अनडिस्प्लेस्ड और इम्पैक्टेड। यहाँ तो सब ठीक ही चल रहा है, तो क्या करोगे, कंजर्वेटिव मेथड्स दे दो। ठीक है, क्या कर दो, कंजर्वेटिव मेथड्स दे दो। बट बच्चे जहां पर भी मैंने आपको बताया ना प्रोसेसेस नहीं लिखना, वहां स्क्रू लिखना ही लिखना है। देखो स्क्रू फिक्सेशन, स्क्रू फिक्सेशन, स्क्रू। ठीक है, कंजर्वेटिव मेथड स्क्रू। एक थॉमस प्लिंट जो है वो आप लोगों को याद रखना पड़ेगा, थॉमस प्लिंट वो भी कंजर्वेटिव मेथड ही है इमोबिलाइजेशन के लिए। सो गाइज सीआर को स्क्रू करो, हाँ बच्चे वो तो सब करते ही हैं, कोई नई बात नहीं है उसमें। सो गाइज वी हैव इन द चैट सेक्शन डॉक्टर तिलक दीक्षित, ही इज अ वेरी 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 ब्रिलियंट फैकल्टी। सर के खुद के लेक्चर्स जो हैं सर्जरी के वो आप देख सकते हैं हमारे मेड अकेडमी चैनल पे। इज अ वेरी ब्रिलियंट टीचर एंड वन ऑफ माय फेवरेट टीचर्स। सो गाइज make sure that you go through sir's lecture and be perfect and master of surgery. चलो बच्चे, coming on to the management of late presenting cases. So you know we live in India. ठीक है, and India, okay, so what I should say, so we have IST. Generally people call it as Indian Standard Time, but definitely it is not Indian Standard Time, it is Indian Slow Time. Okay, so our time is something that works very late. ठीक है, तो इसीलिए we have seen very high chances of late presentations. ठीक है, in our scenarios in India, yes, there are a lot of cases of late presentations. And in the late presentation what we are supposed to do, okay, so if the patient is presenting to you late, Hanji, what you will do? So in the cases of late presentation, my dear students, please understand, we have to check the age of the patient. If the age of the patient is more than 60 years, again I have told you we have to do the, देखो अब तो सब वर्ष हो गया, एक तो 60 साल से ऊपर, ऊपर से आए लेट, तो हम लोग को क्या करना पड़ेगा, रिप्लेसमेंट आर्थ्रोप्लास्टी। रिप्लेसमेंट आर्थ्रोप्लास्टी मतलब इतना लेट हो चुका है कि जुड़ने के चांसेस ही नहीं है, वी हैव टू डू रिप्लेसमेंट आर्थ्रोप्लास्टी। बट वही मान लीजिए कोई यंग पेशेंट है, ठीक है, यंग पेशेंट, सलमान खान भाई ऑलवेज यंग, चलो भाई। सो इफ द पेशेंट इज यंग वी हैव टू चेक द हेड। ओके, वी हैव टू चेक द हेड। ठीक है, सलमान खान जी आ गए, किसका हेड देखेंगे, हाँ ब्लैक डियर का, मारूंगा थप्पड़। देखो किस चीज का हेड देखोगे, हेड ऑफ फीमर। ठीक है, हेड ऑफ फीमर, सो वी विल चेक द head of the femur. Okay, so if the head of, I just hope Salman Khan sir never watches this session. ठीक है, so head of femur हम लोग को देखना है if it is vascular or if it is avascular. ठीक है, if it is vascular or if it is avascular. बच्चे लिख रहे हैं कमेंट सेक्शन में, नहीं सर वो तो एज तो उनकी 60 से ज्यादा है। ठीक है बेटा, लॉरेंस बिश्नोई का एग्जांपल ले लो। ठीक है, लॉरेंस बिश्नोई, एक खतरनाक नहीं अच्छा लग रहा, दूसरा खतरनाक ले लो, कोई बात नहीं। हेड ऑफ फीमर बच्चे, हेड ऑफ फीमर इफ इट इज वैस्कुलर वी डू दी, बड़ा ही बढ़िया नाम। सो इफ इट इज वैस्कुलर तो हम क्या बोलते हैं, हुर्रे, क्या बोलते हैं, इफ इट इज वैस्कुलर बोलते हैं हुर्रे। सो वी विल डू मैकमुर्रे। ठीक है, मैकमुरेज ऑपरेशन। ठीक है, वी डू व्हाट, वी डू द मैकमुरेज ऑपरेशन। ओके, और मैकमुरेज ऑपरेशन, ठीक है, ये आप लोगों को याद रखना है, मैकमुरेज ऑपरेशन। ठीक है, सो ये एम होता है बेटा, एम का उल्टा डब्ल्यू होता है, इधर लिख दो पॉ, इधर लिख दो वेल। एक और ऑपरेशन होता है बेटा, पॉवल्स ऑपरेशन। ठीक है, ये भी हम लोगों को करना है, मैकमुरे। इफ इट इज एवास्कुलर बच्चे, ए से एवास्कुलर होता है बेटा, अल्फाबेट्स में ए के बाद बी आता है, सो बी से क्या करेंगे बेटे, बाइपोलर प्रोस्थेसिस। ठीक है, बाइपोलर प्रोस्थेसिस। ठीक है, बाइपोलर प्रोसेसेस। ठीक है, तो ये जो चीजें हैं बच्चे आपको इसको याद रखनी है। कमिंग ऑन टू द कॉम्प्लिकेशंस। ठीक है, तो कॉम्प्लिकेशंस, तो देखो हर हर ऑर्थो की जो बात आएगी ना उसमें कॉम्प्लिकेशंस आएंगी बेटा, क्योंकि हमें गाली गलौज की आदत होती है और ठीक है रिश्तेदारी में ये सब चलता नहीं। चलो जो भी है, कॉम्प्लिकेशंस, कॉम्प्लिकेशंस में क्या क्या पढ़ना है बेटे? पहले पढ़ना है नॉन यूनियन। देखो भाई सीधी सी बात है, नो बकवास है। इंटरट्रोकेंट्रिक फ्रैक्चर में मैंने पढ़ाया था माल यूनियन, नेक ऑफ फीमर फ्रैक्चर में मैंने पढ़ाया नॉन यूनियन। क्यों? क्योंकि बेटा नेक ऑफ फीमर फ्रैक्चर शुरू होता है एन से और यहाँ पर होगी नॉन यूनियन। ठीक है, इसीलिए आप याद कर लोगे कि आईटी फ्रैक्चर में क्या होता है बेटा, आईटी फ्रैक्चर में होता है माल यूनियन। नॉन यूनियन के बाद हम लोग बात करेंगे ए वैस्कुलर नेक्रोसिस, ए वैस्कुलर नेक्रोसिस। ठीक है, और उसके बाद हम लोग बात करेंगे बेटा ऑस्टियो आर्थराइटिस, उसके बाद हम बात करेंगे ऑस्टियो आर्थराइटिस के बारे में। ठीक है, सो नॉन यूनियन, ए वैस्कुलर नेक्रोसिस एंड ऑस्टियो आर्थराइटिस। सो नॉन यूनियन हम देखते ही हैं कि ये बहुत ज्यादा होता है। ठीक है, और इसीलिए हम लोग, मैं आपको बताता हूँ ये होता क्यों है, वाई नॉन यूनियन, बिकॉज एक तो इमोबिलाइजेशन की वजह से। ठीक है, बिकॉज ऑफ immobilization, number one thing, and second important thing which why non-union occurs is the poor blood supply. Okay, next is what? Next is the poor blood supply. ठीक है, पुअर ब्लड सप्लाई। सो ब्लड सप्लाई खराब है, इमोबिलाइजेशन हो रखा है, तो क्या करेंगे? तो करेंगे बच्चे ये चेक करेंगे कि इफ द पेशेंट इज एल्डरली और द पेशेंट इज यंग, इफ द पेशेंट इज एल्डरली और द पेशेंट इज यंग। अगर पेशेंट एल्डरली निकला तो क्या करोगे? तो आप करोगे रिप्लेसमेंट आर्थ्रोप्लास्टी, रिप्लेसमेंट आर्थ्रोप्लास्टी। ठीक है, रिप्लेसमेंट आर्थ्रोप्लास्टी। एंड इफ द पेशेंट इज यंग देन व्हाट वी विल डू नेक रिकंस्ट्रक्शन, नेक रिकंस्ट्रक्शन। नहीं तो जो आप लोगों को बताया था यंग पेशेंट्स में पावल्स ऑपरेशन भी जो है वो आप लोग कर सकते हो। ठीक है, पावल्स ऑपरेशन भी जो है, पावल्स ऑपरेशन और पावल्स ऑस्टियोटमी इज समथिंग दैट यू कैन डू। कमिंग ऑन टू बेटा ए वास्कुलर नेक्रोसिस, बताओ जिसके पास ब्लड ही नहीं बचा है, ठीक है, वहां क्या करेंगे हम लोग? क्या करेंगे? ए वास्कुलर नेक्रोसिस, भाई सीधी सी बात है, एल्डर पेशेंट है, हेमी आर्थ्रोप्लास्टी, हेमी आर्थ्रोप्लास्टी, हेमी आर्थ्रोप्लास्टी। ठीक है, और अगर यंग पेशेंट है तो क्या करेंगे? यंग पेशेंट के अंदर में क्या करते हैं बेटा? यंग पेशेंट में आप लोग करते हो बाइपोलर रिप्लेसमेंट, बाइपोलर रिप्लेसमेंट, or you can do what? You can do the Mayer's procedure, Mayer's procedure। ओके, मेयर्स प्रोसीजर। अब बच्चे बोलते हैं सर ये हमें याद नहीं रहता। बेटा सिंपल सी बात है, याद रखो बॉम्बे। ओके, याद रखो बॉम्बे। सो बी से होता है बाइपोलर प्रोसेसेस। ठीक है, ए से होता है बेटा एवास्कुलर नेक्रोसिस, ए से होता है एवास्कुलर नेक्रोसिस। ओके, एम से तुम्हारा होता है क्या बच्चे? मायस। ठीक है, एंड वाई और ओ मिला दोगे तो क्या बन जाएगा बच्चा? यंग। ठीक है, फिर से बता देता हूँ, बी से है बॉम्बे में BOMBAY, ए से होता है एवास्कुलर नेक्रोसिस, वाई और ओ मिला करके बनते हैं यंग, बी से होता है बाइपोलर रिप्लेसमेंट, एम से होता है तुम्हारा मेयर्स ऑपरेशन। ओके, मेयर्स ऑपरेशन, वेरी 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 इंपॉर्टेंट। कमिंग ऑन टू ऑस्टियोआर्थराइटिस, व्हाई डज इट हैपन? सो देखो ये होता है बच्चा इसलिए क्योंकि देयर इज अ एवास्कुलर डिफॉर्मिटी। ठीक है, सो एवास्कुलर डिफॉर्मिटी, ठीक है, वहां पे आपका ब्लड सप्लाई ही नहीं है प्रॉपर, सो इन्फ्लेमेशन होना जायज है, दैट इज एवास्कुलर डिफॉर्मिटी दैट्स गोइंग टू हैपन। एंड व्हाट डू यू डू इफ इट इज अ यंग पेशेंट? यू विल डू आईटी ऑस्टियोटमी। ओके, आईटी ऑस्टियोटमी। देखो अर्थराइटिस में आईटी साथ में आता है, सो यू कैन रिमेंबर आईटी ऑस्टियोटमी इज समथिंग व्हिच यू आर गोइंग टू डू। एंड रिमेंबर, इफ यू रिमेंबर दिस टी, रिमेंबर इन THR, total hip replacement done in what? In elderly. Okay, in elderly you are going to do the total hip replacement. So this is it about both of the fracture, and now let me just differentiate between the two fractures one by one about the neck of femur fracture and the intertrochanteric fracture। ठीक है, नेक ऑफ फीमर फ्रैक्चर के बारे में और इंटरट्रोकैंटर फ्रैक्चर के बारे में हम लोग क्या करेंगे, अभी इसको डिफरेंशिएट करेंगे। So here we will write the neck of, okay, neck of femur fracture, and यहाँ हम लोग लिखेंगे इंटरट्रोकैंट्रिक फ्रैक्चर। सीधी सी बात है बेटा, बहुत सिंपल सी चीज है, कुछ परेशान होने की जरूरत नहीं है। नेक ऑफ फीमर फ्रैक्चर किसमें होता है? आफ्टर 50 इयर्स होता है। ठीक है, फीमेल्स में ज्यादा होता है। सो एफ से फीमर होता है, एफ से 50 होता है, एफ से फीमेल होती है, ठीक है, याद रखना। एंड आई शुड नॉट राइट दिस वर्ड फेटल, वो क्योंकि वो एफ से शुरू हो रहा है इसीलिए मैं लिख रहा हूँ, बट रिमेंबर देयर इज अ ट्रिवियल ट्रॉमा, ओके, देयर इज अ ट्रिवियल ट्रॉमा विच इज गोइंग टू बी देयर, ओके। अच्छा, अब एक चीज याद रखो, एफ से ही बेटे फास्ट। सो फास्ट का क्या मतलब है? फास्ट मतलब ऐसे याद रखना कि फास्ट मूवमेंट नहीं, दे आर नॉट एबल टू मूव फास्ट, बट यस वन थिंग विच यू कैन राइट इज दैट एबिलिटी टू मूव इज प्रिजर्व्ड, ठीक है, ability to move is preserved, yes they can move, okay, ability to move is preserved, yes they can walk, okay. Now you have to understand why they can walk, because the pain, the swelling, the ecchymosis, the is little less, okay, the pain, the swelling, the ecchymosis is little less. So pain भी नहीं है बेटा, swelling भी नहीं है, ecchymosis भी नहीं है, तो है क्या? है tenderness, ठीक है। और कहाँ है tenderness? स्कारपास ट्रायंगल। कहाँ है टेंडरनेस? स्कारपास ट्रायंगल। और स्कारपास ट्रायंगल क्या है वो मुझे कौन बताएगा? MBBS 8981 आप बताओगे स्कारपास ट्रायंगल, ठीक है। सो क्या डिफॉर्मिटी है? तो मैंने बताया ना, टेंडरनेस है, बाकी कुछ नहीं है। सो डिफॉर्मिटी है, दिस इज लेस देन 45 डिग्रीज। एंड शॉर्टनिंग क्या है? तो शॉर्टनिंग भी लेस देन 1 इंच है, ठीक है, छोटा छोटा थोड़ा थोड़ा, लेस देन 1 इंच है और लेस देन 45 डिग्रीज है। एंड आई हैव टोल्ड यू, एन से होता है नेक ऑफ फीमर फ्रैक्चर, एन से होता है नॉन यूनियन, वेयर एज हेयर इट विल बी माल यूनियन। अब इसका सब उल्टा करते जाओ, क्या? मोर देन 50 ईयर्स, तो यहाँ पर आप क्या लिखोगे? मोर देन 60 ईयर्स, ठीक है। इधर फीमेल है, इधर मेल है। यहाँ ट्रिवियल ट्रॉमा है, यहाँ पर भी आपका सिग्निफिकेंट ट्रॉमा होता है, बट नॉट वेरी मच, ठीक है। क्या इट कैन वॉक? नो इट कैन नॉट वॉक। पेन वगैरह सब कुछ सीवियर सीवियर सीवियर, ओके। व्हाट अबाउट द टेंडरनेस? टेंडरनेस is going to be there where? On the greater trochanter. This is one thing which you have to remember, that scarpa's region में होता है तो नेक ऑफ फीमर है, ग्रेटर ट्रोकेंटर में होता है तो वो आईटी फ्रैक्चर है। यस, मोर देन 45 डिग्रीज, यस मोर देन 1 इंच इज गोइंग टू बी दैट, ठीक है। तो ये चीज जो है आप लोगों को याद रखनी है, ठीक है। तो ये हमने डिफरेंस की भी बात कर ली इसमें, ठीक है। अब हम लोग चलते हैं, थोड़ा बहुत केस डिस्कशन करते हैं, और केस डिस्कशन के बाद यदि हो पाया तो मैं आप लोगों को, हाँ ये देखो, neck of femur fracture. Can you see this is the neck of the femur? This part is the neck of the femur, and this is the fracture line. This is the fracture line. So neck of the femur fracture. Neck of femur fracture is there. ठीक है? Neck of femur fracture is going to be there. And also one important thing which you have to understand. ठीक है? This is not really good presentation. Otherwise one thing, देखो ये जो ये चीज होती है ना, लेसर ट्यूबरकल, ये लेसर ट्यूबरकल ना हमेशा मीडियली होता है, ठीक है, दिखता नहीं है ज्यादातर केसेस में, अच्छे एक्सरेज में। यदि वो आपको दिख रहा है, ठीक है, यदि वो आप लोगों को दिख रहा है, so what you have to understand that this has been externally rotated, and this external rotation is something that is seen in neck of femur fracture, ठीक है, in neck of femur fracture में हम लोगों को दिखता है। so NOF is important, ठीक है, बाकी हम लोग डिस्कस करेंगे। चलो ये क्वेश्चन देखो, 72-year-old फीमेल, पहली चीज तो क्या है कि इट इज मोर देन 60 ईयर्स, बट दूसरी चीज क्या है? इट इज फीमेल, तो कांट इट बी, है ना। तो फीमेल के अंदर में प्रेजेंट टू द इमरजेंसी डिपार्टमेंट, प्रेजेंस टू द इमरजेंसी डिपार्टमेंट आफ्टर स्लिपिंग। सो आई हैव टोल्ड यू दिस इज वन ऑफ द रिस्क फैक्टर्स। गिर जाना, बाथरूम में गिर जाना, ये किसके लिए होता है? आईटी फ्रैक्चर के लिए, इन द बाथरूम। शी कंप्लेन्स ऑफ सीवियर पेन इन द राइट हिप, अनेबल टू स्टैंड और बियर वेट। सो अनेबल टू बियर वेट, दिस इज अगेन important. On examination, the right lower limb is shortened and externally rotated. ये बात आते ही आप लोगों को एक ही चीज समझ में आनी चाहिए, इट इज शॉर्टेंड, इट इज एक्सटर्नली रोटेटेड। क्या लगता है क्या होगा? हाँ जी, क्या लगता है क्या होगा? इट कैन बी आइदर नेक ऑफ फीमर फ्रैक्चर और इट कैन बी, हाँ जी, और नेक ऑफ फीमर फ्रैक्चर भी हो सकता है, आईटी फ्रैक्चर भी हो सकता है, ठीक है, शॉर्टेंड एंड एक्सटर्नल। ओके, जस्ट 1 सेकेंड, आई थिंक आईटी भी हो सकता है, नेक ऑफ फीमर भी हो सकता है। दिस क्वेश्चन इज नॉट करेक्टली फ्रेम्ड, लेट मी जस्ट, okay, The next they write there is tenderness over the trochanteric region also. बेटा ग्रेटर ट्रोकैंटर में यदि हम लोगों को देखो वही बातें हैं ना सारी, ग्रेटर ट्रोकैंट्रिक रीजन के अंदर में, ट्रोकैंट्रिक रीजन के अंदर में अगर इसको पेन मिल रहा है, so what you have to understand that this is a IT fracture, IT fracture. Okay, shortening is there and significant shortening है, more than 1 inch है, so yes it is going to be an IT fracture. So externally rotated देके थोड़ा confuse कर दिया, नहीं देते तो ज्यादा अच्छा था, but anyways nothing else. And making it very obvious, fracture line extending between the greater and lesser trochanters, completely एक ही लाइन में आंसर है, this is nothing else but the intertrochanteric fracture. So this is the way to do the intertrochanteric fracture, right? Coming on to the this one बच्चे, this is a 65-year old, हालांकि इसमें भी more than 60 years दे रखा है, so it can be both. ठीक है, it can be both. Why? Because more than 60 years is anyways more than 50 years. ठीक है, so it can be both. Presence after a trivial fall, he complains of groin pain. बेटा ये देखो, ये important चीज है, groin में अगर पेन आ गया तो क्या होगा? This is a neck of, sorry, this is a neck of femur fracture. अभी तक आगे देखते हैं. Inability to walk, बिल्कुल सही बात है. Affected limb is shortened, it is externally rotated, दोनों में ही दिखता है, not a very significant thing. ठीक है, इट शोज अ फ्रैक्चर थ्रू द नेक ऑफ फीमर. अब ये दे दिया तो इससे ज्यादा कुछ नहीं दे सकते, नेक ऑफ फीमर दे दिया है, सो इट्स गोइंग टू बी नेक ऑफ फीमर फ्रैक्चर. ओके, नेक ऑफ फीमर फ्रैक्चर इज गोइंग टू बी देयर. ठीक है, नेक ऑफ फीमर फ्रैक्चर इज गोइंग टू बी देयर. सो बच्चे हम लोगों ने डिस्कस कर लिया है अभी तक अबाउट द इंटरट्रोकेंट्रिक फ्रैक्चर, अबाउट द नेक ऑफ फीमर फ्रैक्चर. नेक्स्ट टॉपिक ऑफ डिस्कशन इज गोइंग टू बी पोस्टीरियर डिस्लोकेशन ऑफ हिप. ठीक है, नेक्स्ट टॉपिक ऑफ डिस्कशन इज गोइंग टू बी पोस्टीरियर डिस्लोकेशन ऑफ हिप. ठीक है, चलिए. सो posterior dislocation of hip. ठीक है, तो posterior dislocation of hip हमारा नेक्स्ट टॉपिक है और इसको हम लोग डिस्कस करेंगे आफ्टर अ शॉर्ट 10 minutes ब्रेक. तो वी विल मीट एट 6:55 PM. ओके, विल मीट एट 6:55 PM. सो आई थिंक आप लोगों को समझ में आ रहा है, समझ में आ रहा है तो एक अच्छा सा हार्ट और कुछ गुड सा इमोजी जो है हम लोगों को फटाफट से आप कमेंट सेक्शन में डाल दो. ठीक है, ताकि हम लोग को भी समझ में आए कि आप लोगों को समझ में आ रहा है ना. So MBBS 89 81 says it was a great. No, but it is a great session. We have just taken a 10 minutes break and I'll be right back. Okay, I'll be right back. हेलो, एक ब्रेक दे देते 10 मिनट का ना. ठीक है, एक ब्रेक ले लेते हैं 10 मिनट्स का, उसके बाद में विल मीट. चलो, टेक केयर. हाँ बच्चों, चलिए वेलकम बैक। देखते हैं आवाज आ रही है कि नहीं। ठीक है। हाँ बच्चों, चलिए वेलकम बैक। देखते हैं आवाज आ रही है कि नहीं। ठीक है। चलो, एवरीथिंग इज गुड, फाइन। लेट्स अंडरस्टैंड अबाउट द next topic of discussion, and the next topic is posterior dislocation of hip. ठीक है। सॉरी यार। चलो, सो पोस्टीरियर डिसलोकेशन ऑफ हिप ऐसा नहीं है जैसे कल मैंने एंटीरियर डिसलोकेशन ऑफ शोल्डर पढ़ाया था, तो बच्चे बोल रहे थे कि सर शोल्डर में सिर्फ एंटीरियर डिसलोकेशन ही होती है क्या। ऐसा नहीं होता। सिमिलरली पोस्टीरियर डिसलोकेशन ऑफ हिप का मतलब ये नहीं है कि सिर्फ पोस्टीरियर डिसलोकेशन ही होगी। ठीक है। यदि आप एक ब्रॉडर एस्पेक्ट पे बात करोगे तो डिसलोकेशन ऑफ हिप जो होती है वो तीन तरीके की होती है। वन इज एंटीरियर, देन इज पोस्टीरियर, एंड देन इज सेंट्रल फ्रैक्चर डिसलोकेशन। ओके, एंटीरियर, पोस्टीरियर एंड सेंट्रल। सेंट्रल का मतलब होता है फ्रैक्चर डिसलोकेशन। ठीक है। Fracture dislocation, central fracture dislocation. Now, why I am taking posterior dislocation of hip as the topic? Because posterior dislocation is something that is seen most commonly. So posterior dislocation is something that is seen most commonly. So most common dislocation of hip is posterior dislocation. Posterior dislocation. Coming on to the introduction. अच्छा, पहले तो हमने क्या क्या डिस्कस करना है इसमें मैं आपको वो बता देता हूँ. So we'll discuss a little bit about the intro part, and after intro we'll discuss about the mechanism. Okay, then we'll discuss about the clinical features, then the radiology, and then the treatment part. Okay, the treatment modalities. हाँ जी, MBBS 8981 अंजलि, आप लोग साथ हो बेटा हमारे? Yes, are you guys with me? हाँ जी. So everyone who has joined, just give a quick thumbs up. Okay. And okay, great, great, great. So intro, mechanism, clinical features, radiology, then the treatment and the management part, and then we will discuss about the complications. So this is going to be this is the gist of the topic, how we are going to discuss about your what about your posterior dislocation of hip. Okay, posterior dislocation of hip. So posterior dislocation of hip, what do you mean by that? See, in this case, the head of femur is going to be pushed out of the acetabulum. So you know that normally the head of femur is inside the acetabulum. So now head of femur is pushed out. Understand? Head of femur is pushed out of acetabulum. So it is pushed out of the acetabulum. Okay. And associated with a chip fracture. Associated with a chip fracture of what? Of posterior lip of acetabulum. Okay, posterior lip of acetabulum. So this is something that is really, really important, that head of femur is pushed out of the acetabulum, and where it is pushed? Posteriorly. Okay, posteriorly, which is something that is associated with chip fracture of posterior lip of acetabulum. Okay, in about 50% of cases. Okay, in 50% of cases, and there is it is called as fracture dislocation. ठीक है, इसको आप क्या बोलेंगे? इसको आप बोलेंगे fracture dislocation. Okay, fracture dislocation. Okay. Now, so what happens is the mechanism, if we talk about. So there is a shaft of femur, okay, with the hip flexed. So for example, this is the hip flexion which I am trying to tell you. Okay, hip flexion. So hip flexed, and there is a force which is going to come along the shaft of femur. Okay, So shaft of femur. So a force is going to come along the shaft of femur, directed along the shaft of the femur with the hip flexion, which is generally seen. So when do you see the hip flexion? So for example, you are sitting on a motorbike. Okay, so road traffic accidents are the most common places where we see this kind of problem. Okay, right? Motor vehicle accidents. Okay, right? And when it is seen, like for example, okay, I'll teach you, I'll try and teach you. Please don't make this diagram in your um, exams. Okay, it's just my way of teaching you guys. Okay, so for example, so this is the steering, this is the window, and this is the driver. So driver is driving, and this is the dashboard. Okay, so for example, if the driver is thrown out of the car, and this dashboard hits the flexed hip, it is going to hit the okay, so what is going to happen in this? See, the hip is in flexion, flexed hip. Okay, force from dashboard force from the dashboard hits along the axis of femur. Okay, so hits along the axis of femur. Okay, hits along the axis of femur. Okay, and this is something which is called as what? This is something which is called as dashboard injury. So the dashboard injury, number one, and number two is your, हाँ जी, दूसरी चीज हमने क्या बताई है आप लोगों को? नहीं, अच्छा ठीक है, डैशबोर्ड इंजरी बताया अभी तक. ठीक है, डैशबोर्ड इंजरी इज समथिंग दैट इज रिस्पॉन्सिबल फॉर कॉजिंग द पोस्टीरियर डिसलोकेशन ऑफ द हिप. ठीक है, सो जो ये पोस्टीरियर डिसलोकेशन है, इसका आपको मैकेनिज्म भी समझ में आ गया. अब हम लोग डिस्कस करेंगे अबाउट द क्लिनिकल फीचर्स. तो क्या क्लिनिकल फीचर्स हो सकते हैं पोस्टीरियर डिसलोकेशन ऑफ द हिप के? देखो भाई, कोई भी कहीं से लोकेट होता है. तुम्हारी बंदी थी, तुम्हारी बंदी ने तुम्हें छोड़ा, नए बॉयफ्रेंड पे चली गई, डिसलोकेट हो गई. डिसलोकेट हुई मतलब क्या? हिस्ट्री ऑफ सीवियर ट्रॉमा. बेवफा, बेवफा, बेवफा निकली है तू. हाँ, सो हिस्ट्री ऑफ सीवियर ट्रॉमा. ठीक है, पेन रहेगा, बिल्कुल. स्वेलिंग रहेगी, बिल्कुल. ठीक है, पेन भी होगा, स्वेलिंग भी होगी, और क्या होगा? डिफॉर्मिटी. डिफॉर्मिटी, अब कौन सी डिफॉर्मिटी होती है? FADIR, फादर. फादर. ओके, ये डिफॉर्मिटी होती है. MBBS 8981, मैं तो सिंगल हूं. कोई बात नहीं बेटा, सबका क्या बोलते हैं, सिस्टम सबके निकलेंगे क्या, कुछ ऐसे बोलते हैं ना. सो फ्लेक्शन इज गोइंग टू बी देयर, एडक्शन इज गोइंग टू बी देयर, and IR, internal rotation. Okay, so flexion, adduction, and internal rotation is something that is the deformity that's going to take place. Okay, right? Please remember, this is associated with shortening of limb. Okay, this is something which is associated with shortening of limb. ठीक है, तो limb जो है वो क्या हो जाएगा? Limb will be shortened. There will be shortening of the limb, shortening of the leg. ठीक है, and because the head of femur is going to go पीछे, so it will be palpated in पिछवाड़े में. Head of femur is going where? Head of femur can be palpated in gluteal region. So can be palpated in which region, bache? It is palpated in the gluteal region. You can palpate the head of the femur. Okay, right? So these are really, really important things. Okay, coming on to the next one, this the radiology. Okay, so if you focus on the radiological examination, just remember that of course the femur head, of course the femur head is out of acetabulum. ठीक है, जो हेड ऑफ फीमर होता है वो कहाँ निकल जाता है? दैट इज गोइंग आउट ऑफ द एसेटाबुलम. ठीक है, एंड योर थाई, as I've told you, is internally rotated. Okay, your thigh is internally rotated, and if the thigh is internally rotated, remember your lesser trochanter will never be visible. Okay, your lesser trochanter will never be visible. Okay, lesser trochanter be never be visible. तो ये इंपॉर्टेंट चीज है, लेसर ट्रोकैंटर जो है वो कभी भी नहीं दिखेगा, क्योंकि ये और अंदर की तरफ इंटरनली रोटेट हो चुकी है. फादर was the mnemonic, so it is internally rotated. Internally rotated. Of course, the sentence arc or sentence line is going to be broken. I've told you what do you mean by sentence arc or sentence line. The sentence line is going to, or arc is going to be broken. Okay, it is going to be what? It is going to be broken. And if you can just see, then please look out for the broken chip. Okay, broken chip from the acetabulum should be looked upon. Okay, broken chip from the acetabulum should be searched. Okay, should be looked after, and if you can just look, and accordingly you can remove it out. Okay, so really important these things, and yes, we do the CT and MRI also, because there are high chances of soft tissue injury. Okay, high chances of soft tissue injury in this. Okay, soft tissue injury. Okay, coming on to the management part. Okay, coming on to what? Coming on to the management part. So again, management is again important. So remember, okay, so just remember that it is a emergency. So why it's an emergency? It's an emergency because the head of the femur is out. It is an emergency because remember that because the head of femur is out of acetabulum, and the more it remains out of the acetabulum, there will be more chances of AVN of femur. So more chances of AVN of femur. Okay, that is avascular necrosis. Okay, avascular necrosis of femur. Okay, there are more chances of avascular necrosis of femur. Okay, that's why what we have to do, either we will do closed reduction, or we will look after open reduction. Okay, either we will do closed reduction, or we will do open reduction. Okay. So what do we do in closed reduction? So please remember, it is you know in most of the cases we do the closed reduction. Hanji, now is it fine? It is fine from my end, Vache. Can you please let me know? Hanji, Rilji.
Sir, from our end, it is okay, sir. No issue. Something issue with the user, sir.
Yeah, now it is fine. Now it is fine. ठीक है, I'm
Yes, sir.
starting. Okay.
Yes, sir. No, okay.
ठीक.
Okay.
All right, beta. All right. So now we can start, I think. Yeah. So what I was trying to tell you, that if it's a posterior dislocation of the hip joint, the best thing to do is to do the closed reduction. Okay. And how to do the closed reduction? So what happens is you have to give general anesthesia to the patient. Okay. Thank you, Dr. Harshvardhan. And it's lagging again. हाँ जी, अब ठीक है ना? चलो, तो देखो क्या करना है आप लोगों को. What you are supposed to do, you have to give the general anesthesia to this patient. Once you give the general anesthesia to the patient, and your patient is it is in supine position, so give a the helper, the attendant, okay, he or she is supposed to firmly hold the pelvis. Okay, and what you will do, the surgeon is going to flex the hip. Okay, the surgeon is going to do what? It is going, or he or she is going to flex the hip. Okay, and once the surgeon is flexing the hip, now comes the important part. Okay, now comes the important part. देखो भाई, हो क्या रहा है, this is a posterior dislocation of the hip. ठीक है, that means the head of the femur has gone out and now it is looking posteriorly. Okay, it is looking where? It is looking posteriorly. So what we are supposed to do, flex the hip, okay, and right angle and exert an एक्सियल पुल. ओके, देखो अभी इधर से आप लोगों को पुल करना है, दिस यू आर सपोज टू पुल एंड दिस इज पुश्ड ओवर हियर. सो flex the hip at 90 degree and pull. Okay, and exert a pull. Okay, pull exert करोगे, ठीक है, you will pull the what I should say, you should pull, axial pull. ठीक है, exert an axial pull. Okay, and what will be there? हाँ जी, what will be there? There will be a sound of reduction that will occur, and after this sound of reduction, once this sound is coming, what is going to happen next? Hip will be ready to move in all direction. Hip moves in all direction. Okay, so this is very important. This you have to understand, that you give general anesthesia, patient is supine position, gas the pelvis firmly, flex the hip, give an axial pull, sound of reduction will come, and yes, hip will be ready to move in all the direction. ठीक है, सो ये हो गया हमारा क्लोज रिडक्शन की रेसिपी. अब हम रेसिपी बनाएंगे किस चीज की? ओपन रिडक्शन की. ठीक है, अब हम बात करते हैं अबाउट द ओपन रिडक्शन. ठीक है, तो देखो ओपन रिडक्शन हर केस में तो नहीं चाहिए होता, कुछ एक केसेस में ओपन रिडक्शन भी रिक्वायर्ड है. जैसे कि देखो मान लो क्लोज रिलेशन खराब हो जाए तो, ठीक है, क्लोज रिलेशन नहीं, सॉरी, क्लोज रिडक्शन. ठीक है, अगर क्लोज रिडक्शन नहीं हो रहा है, क्लोज रिडक्शन इज नॉट प्रॉपर. ओके, इफ द क्लोज रिडक्शन इज फेलिंग, यू हैव टू डू व्हाट? यू हैव टू डू द open reduction. Okay, then there is an intra-articular loose fragment that is not allowing the accurate reduction. Okay, sometimes what happens is, now posterior dislocation हो गया है, उसके बाद में intra-articular मतलब between the acetabulum and the head of the femur, if you are having what, if you are having intra-articular fragment, okay, that is preventing, okay, intra-articular fragment that prevents the close reduction. So ऐसे cases के अंदर में what you can do, you can definitely do a open reduction. Okay, and one important thing is, sometimes what happens is that acetabular fragment, ठीक है, मैंने बताया था ना कि that's a chip fracture. So if the fragment of this acetabulum is large, ठीक है, ज्यादा बड़ा जो fragment है वो टूट चुका है, ठीक है, or it is from the weight bearing, okay, it is from the weight bearing part of acetabulum. ठीक है, a weight bearing part of acetabulum, ठीक है, weight bearing part of acetabulum, इन दोनों cases के अंदर में it is not possible to do the close reduction, not possible to do the close reduction. Guys, before I discuss the complications, okay, before I discuss the complications, we have with us in the comment box Dr. Harshvardhan. Dr. Harshvardhan is a very brilliant practitioner. Believe me, very good hands-on skill when it comes to the practice of obstetrics and gynecology. And he was thinking to opt for the same. I don't know if he has taken this branch right now or not, but yeah, I wish him a very good luck. Wishing him all the very best. ठीक है, चलिए discussing about the complications. So complications, first important thing, which is the nerve which is lying behind. So nerve is sciatic nerve. So just remember that sciatic nerve damage. Okay, so sciatic nerve can be damaged. Okay, sciatic nerve can be damaged. Okay, then who is going to go to that nerve? Of course, the head of the femur. So head of femur is going to go to the nerve, and I have already told you that head of femur is really important. Why? Because it can go into avascular necrosis. Okay, avascular necrosis of the head of the femur can occur. Okay, so this is really important thing. So what you have to do, Hanji, what you have to do in this case? So you have to detect this very early. And how will you detect this? Because the patient is going to present with the pain in hip. Okay, pain in the hip suddenly. Okay, pain in hip after a painless period. Okay, pain in the hip after a painless period of how much time? Hanji, period of how much time? approximately 1 to 2 years after injury. Okay, 1 to 2 years after injury, suddenly this pain is going to arise. Why? Because the head of femur is going to have what? Is going to have the avascular necrosis. Can there be myositis ossificans? देखो बिल्कुल हो सकता है myositis ossificans, खास करके उन पेशेंट्स में होता है जो एम से क्या कर, एम से myositis ossificans, एम से मसाज, जिन लोगों को मसाज वसाज कराने की ज्यादा आदत होती है उनको मायोसाइटिस ऑसिफिकेंस होता है। तो होता क्या है मायोसाइटिस ऑसिफिकेंस? दिस इज एन इन्फ्लेमेशन ऑफ मसल मायोसाइटिस एंड bone fragments bone fragments start to grow in this muscle. Okay, so some bone fragments will start to grow in these muscles. Okay, in these muscles these bone fragments are going to start to grow. Okay, this is myositis ossificans. So what to do? Please give rest to the patient, don't do the massage and all. Please give rest to the patient. And since it's an inflammation, so of course some anti-inflammatory, especially analgesics, something analgesics and anti-inflammatories are something which we give. Okay, so these are important things. Coming on to the osteoarthritis, last complication, osteoarthritis. So this is again an important problem, osteoarthritis. Although, just remember, it's a very late complication. Okay, it's a very late complication, osteoarthritis. Okay, and but this is again an emergency. Why? Because osteoarthritis, we have seen, is responsible for causing the avascular necrosis of the head of the femur, and yes, uh, or I should say कि it is associated with. So basically AVN is responsible for causing the osteoarthritis. So that's why we have to deal it with a very vigilant care, because one of the causes of osteoarthritis is nothing else but your avascular necrosis. And if the osteoarthritis is there, please remember we have to do total hip replacement. Okay, this is the treatment. Total hip replacement has to be done. Okay, total hip replacement has to be done in this case. So this was about the posterior hip dislocation. posterior hip dislocation. हाँ जी, ठीक है जी, समझ में आ गया आप लोगों को? यस, ओके। चलिए एक क्वेश्चन सॉल्व करेंगे, then we will move on to the next part. I think I have taken that or not, मुझे देखना पड़ेगा. हाँ, see here. So can you see this? This is the father deformity, है ना? Father deformity. Okay, there is a adduction which is there. Okay, there is a internal rotation which is there. There is a slight flexion also which is there. Okay, so flexion, adduction and internal rotation, this is the deformity which is there, and you can very well see that there is no lesser tubercle. Okay, there is no lesser tubercle. Okay, lesser tubercle है, नहीं दिख रहा है, ठीक है, नहीं दिख रहा है. Okay, so again this is again important for posterior dislocation of hip. ठीक है, तो posterior dislocation बहुत important है, इसको भूलना नहीं है. अच्छा, पॉट्स फ्रैक्चर भी पढ़ाना है, ठीक है जी, पढ़ा देंगे जी, पॉट्स फ्रैक्चर भी पढ़ा देंगे, ठीक है. ओके, आई विल मार्क हियर, यहाँ लिख लेता हूँ मैं पॉट्स फ्रैक्चर. इस हिसाब से क्लास तो तुम्हारी 9 बजे तक चलेगी, हाँ? नहीं नहीं, जल्दी खत्म करेंगे, बिकॉज ऑल दीज टॉपिक्स व्हिच आई हैव डिस्कस्ड सो फार, दीज टॉपिक्स वर दी हेवी टॉपिक्स. ठीक है, चलो पॉट्स फ्रैक्चर भी पढ़ाना, तो पहले पॉट्स फ्रैक्चर ही पढ़ लो. ठीक है, लेट्स डिस्कस पॉट्स फ्रैक्चर. Okay, and then we will go on to the coxa vera. Okay, so now let me teach you about the Pott's fracture. Chaliye beta. So turning to this topic of Pott's fracture, just remember we will discuss about the definition, mechanisms. Okay, so how we are going to, this is commonly asked as a short note. So I'll discuss the definition, then we'll discuss the mechanism. Okay, then we'll move on to the classification, because classification is really important part. Then of course the clinical features, radiology. Okay, clinical features we'll discuss the radiological aspects of Pott's fracture, and in the end we'll move on to the treatment. Okay, we'll move on to the treatment part. Okay, हाँ जी, ठीक है. So I guess now we can move on to हाँ जी, चलो बच्चे, coming on to the so sorry, POTS fracture. So it's the fracture dislocation of, ठीक है, POTS fracture क्या होता है? So it's the fracture dislocation of course it's a fracture, of course it's a dislocation, fracture dislocation of bones forming the ankle joint. Okay, so the bones which are going to form the ankle joint, this is a fracture dislocation of them. So fracture dislocation of the bones forming the ankle joint, this is the definition. Okay, and why does it occur? How does it occur? Either there will be a bending or there will be a twisting. Okay, some bending injury can be there, twisting injury can be there. So bending injury or twisting injury of ankle is responsible for POTS fracture. Bending injury is possible or twisting injury is responsible for doing the POTS fracture. Okay, coming on to the classification now. So let's understand about the classification. ठीक है, बाद में हम लोग I'll write the headings for you. So the classification says that it's a, okay, which classification is there? This is the Lodge-Henson classification. Lodge-Henson classification. So Lodge-Henson, as per Lodge-Henson classification, there are 5 important things which you have to understand. Either this is going to be an adduction injury, either it is going to be an adduction injury, or it is going to be an abduction injury, adduction injury, abduction injury, pronation external rotation injury, pronation external rotation injury, supination external rotation injury, supination external rotation injury, or vertical compression. So these are 4-5 important things when it comes to your, Hanji, when it comes to what? When it comes to your POTS fracture. Okay. So what happens now? You have to understand that you have got 3 important things when it comes to the ankle. So you have got the medial side, you have got the lateral side. Okay, you have got the medial side, you have got the lateral side, and out of the medial side and the lateral side, you have got the uh one more thing. Okay, wait, I need some space. ठीक है, मीडियल साइड रहेगा, लैटरल साइड रहता है, और एक और चीज रहती है बेटा जिसको हम लोग बोलते हैं टीबियो फिब्युलर सिंडेस्मोसिस, टीबियो फिब्युलर सिंडेस्मोसिस, ठीक है, सिंडेस्मोसिस, ठीक है, tibiofibular syndesmosis. Now please understand that tibiofibular syndesmosis is only damage if it is a pronation external rotation. So remember PERV. So from my name you can remember PERV, that is pronation external rotation, and here external rotation, and here you will have V मतलब what? V मतलब वाट लग गई, वाट लग गई मतलब the tibiofibular syndesmosis is damaged only and only in pronation and external rotation, whereas it is normal, it is normal, it is normal, it is normal. Okay, whereas it is normal in all the cases, but remember it is gone only in pronation and external rotation injury. Otherwise, it's going to be absolutely normal. So what you have to understand, okay, now for example, if it's an adduction injury, so if you adduct, okay, if you adduct your knee, what is going to happen? There will be bahar niklegi kaun? Lateral malleolus. So there will be avulsion fracture. Okay, there will be avulsion fracture of lateral malleolus. Okay, there will be avulsion fracture of lateral malleolus. And what is going to happen in medial malleolus? Medial malleolus will also be fractured with an oblique line. So medial malleolus fracture, medial malleolus fracture with oblique line. Okay, there will be a medial malleolus fracture with oblique line, oblique fracture line, and In abduction injury, there will be avulsion fracture. Understand? बाहर निकाल रहा हूँ. Abduction, avulsion fracture of what? Avulsion fracture of medial malleolus. Okay, avulsion fracture of medial malleolus, and there will be, हाँ जी, fracture of, बोलो, fracture of lateral malleolus. हाँ जी, fracture of lateral malleolus. ठीक है, lateral malleolus. Okay. We say at the level of ankle mortise, at the level of ankle mortise. Okay. चल, उसके बाद में हम लोग हमारे वाले फ्रैक्चर पे आते हैं, जहां पर हम लोग एक्सटर्नल रोटेशन तो करेंगे ही करेंगे, एक्सटर्नल रोटेशन, बट एक प्रोनेशन करेंगे और एक उसके बाद में हम लोग लैटरल करेंगे. ठीक है, प्रोनेशन करेंगे एंड सुपाइनेशन करेंगे. सो जस्ट रिमेंबर, वेरी इंपॉर्टेंट थिंग, दोनों केसेस के अंदर में ही देयर इज गोइंग टू बी स्पाइरल फ्रैक्चर. There is going to be spiral fracture of fibula above ankle mortise, and in both of the cases there will be transverse fracture. There will be transverse fracture of medial malleolus. Transverse fracture of medial malleolus, that is going to take place for sure. What about vertical compression? So if there is a vertical compression, जैसे आप सोचो कि ऊपर से कोई पत्थर आकर के गिर गया हो. ठीक है, तभी मैं ऊपर देख रहा था. मान लो ऊपर से आकर के कोई पत्थर गिर गया हो, ऐसे केसेस में क्या होने वाला है? देयर इज गोइंग टू बी कॉम्युनेटेड फ्रैक्चर. कॉम्युनेटेड फ्रैक्चर. ओके, किस चीज का? कॉम्युनेटेड फ्रैक्चर ऑफ मीडियल मेलियोलस. कॉम्युनेटेड फ्रैक्चर ऑफ medial malleolus. Okay, distal end of tibia, distal end of tibia and lateral malleolus. ठीक है, and what? And lateral malleolus. So ये सारी चीजों के क्या हो जाते हैं बेटा? फ्रैक्चर हो जाते हैं. So what are the clinical features? Okay, clinical features क्या रहेंगे बच्चे? So clinical features में remember वही सारी चीजें हैं. जहां पर भी फ्रैक्चर आता है, ये दो तीन चीजें तो याद ही रख लो. पेन रहेगा, स्वेलिंग रहेगी, टेंडरनेस बिल्कुल रहेगी, एकाइमोसिस बिल्कुल रहेगा. ठीक है, सो ये तो चीजें आप लोगों को याद रखना ही है. देन और क्या हो सकता है? हाँ जी, लैक ऑफ मूवमेंट. ठीक है, तो ये सारी चीजें जो है बच्चे वो होनी है, ये याद रखना. अब एक चीज आपको पता होना चाहिए यहाँ पर कि जब हम इसका एग्जामिनेशन करते हैं ना, और अगर फ्रैक्चर प्रेजेंट है, सो देयर विल बी क्रेपिटस. ठीक है, देयर विल बी क्रेपिटस. चर 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 की आवाज जरूर आती है. क्रेपिटस इफ देयर इज फ्रैक्चर. ठीक है, इफ देयर इज फ्रैक्चर प्रेजेंट देन देयर विल बी क्रेपिटस, दैट विल बी सी. ओके, एंड वन इंपॉर्टेंट थिंग कि देयर विल बी विजिबल डिफॉर्मिटी. विजिबल डिफॉर्मिटी मतलब जैसे मान लो एंकल या तो एडक्टेड रहेगी या एबडक्टेड रहेगी, तो इस तरीके की जो है प्रॉब्लम्स आप लोगों को जरूर दिखेंगे. ठीक है, कमिंग ऑन टू द रेडियोलॉजिकल इन्वेस्टिगेशंस और एक्सरे की अगर हम लोग बात करते हैं, सो व्हाट यू विल सी ऑन एक्सरे, यू विल first of all you have to do two views. One is going to be the AP view and other is going to be the lateral view. So either you will do the AP view or you will do the lateral view, and what you will see, so you have to check the fracture line. Okay, so you have to check the fracture line of what? Fracture line of three things: of medial malleolus, of lateral malleolus. ठीक है, क्योंकि मीडियल मेलियोलस पे भी फ्रैक्चर है, लैटरल मेलियोलस पे भी फ्रैक्चर है. ठीक है, एंड इन फैक्ट द डिस्टल एंड ऑफ टिबिया. ओके, डिस्टल एंड ऑफ टिबिया. सो यहाँ पर आप लोगों को फ्रैक्चर लाइन जो है वो जरूर चेक करना है. ठीक है, then you have to check for the tibiofibular syndesmosis also. I have told you where it is going to be damaged. ठीक है, tibiofibular syndesmosis also. ठीक है, ये आपको पता होना चाहिए. And one more thing which I have not written but you can remember from this T से T याद रख लो. T से T क्या याद रखना है? Talus. Okay, talus का posterior subluxation. Okay, so posterior subluxation of talus. Posterior subluxation of talus is something that we have to see. Okay, posterior subluxation of talus is something that you have to see. So what will be the treatment? Hanji, what is going to be the treatment? How will you treat this case? So for treatment, just understand that we have to see if it's a fracture with displacement or fracture without displacement, if it's a fracture with dislocation or it's a fracture without dislocation. So one is going to be fracture without dislocation. Fracture without dislocation. So what you will do, you will just immobilize. Okay, you have to just immobilize. And how will you immobilize? Immobilization takes place with the help of below the knee cast. Below the knee cast. For how much time? For approximately 3 to 6 months. ठीक है, for approximately how much time? 3 to 6 months के लिए below the knee cast लगा करके आप लोग क्या कर देंगे, इसको immobilize कर देंगे. But for example, if it's a fracture dislocation, understand this now. If it's a fracture dislocation, then what you will do? Then you can opt for 2 3 methods. ठीक है, so one is going to be conservative. हमेशा मैं यही बोलता हूँ, पहले आप conservative method पे जाओ, conservative के बाद में open reduction, internal fixation, external fixation, इन्हीं पे जाते हैं हम लोग. ठीक है, so if we talk about the conservative methods, just remember we will do close reduction by manipulation under general anesthesia. So close reduction करेंगे. ठीक है, manipulation under general anesthesia. Then of course, as I've told you, we have to use below the knee plaster cast. Okay, below the knee plaster cast is something that we have to use. Okay, and then what else? After doing this plaster cast, you have to perform an X-ray. Okay, if the X-ray, okay, you check with the X-ray. Okay, and if the X-ray is satisfactory, okay, if the X-ray is satisfactory, then we will continue. ठीक है, if the X-ray is satisfactory, then we will continue putting the cast. Okay, continue putting the cast for approximate duration of 8 to 10 weeks more. यानी कि 2 1 महीने 2 2.5 महीने के लिए आप फिर से इसको क्या करेंगे, कास्ट लगा देंगे. ठीक है, और यदि वो एक्सरे जो है वो अनसेटिस्फैक्ट्री है, ठीक है, इफ दैट एक्सरे इज अनसेटिस्फैक्ट्री, फिर हम लोग क्या करते हैं, फिर हम लोग ऑपरेशन की तरफ जाएंगे. अब यहाँ तक होगी, यहाँ तक तो आप लोगों को कोई डाउट नहीं होगा कि हम लोग ऑपरेशन की तरफ जाएंगे. तो ऑपरेटिव मेथड्स में क्या करते हैं बेटा, ऑपरेटिव मेथड्स के अंदर में हम लोग अगर जाएंगे, सो ऑपरेटिव मेथड्स में वी विल गो फॉर ORIF. ठीक है, ओपन रिडक्शन इंटरनल फिक्सेशन. ठीक है, वी गो फॉर ORIF, that is open reduction. Okay, I'll write like this: open reduction plus internal fixation. ठीक है, we'll go for. हाँ जी, is it lagging? कोई बताता ही नहीं है यार. अच्छा, it is not lagging. ठीक है, open reduction plus internal fixation is something that we will do. So what you have to understand that what are the different techniques of internal fixation. तो हमें उसके लिए पता होना चाहिए कि हमारे पास में खराब क्या क्या चीजें होती हैं, है ना. तो पता तो हमें तब लगेगा ना कि हमें किस चीज का इंटरनल फिक्सेशन करना है, जब हमें ये पता होगा कि चीजें खराब क्या क्या होती हैं. सो योर मीडियल मेल्यूलस कैन गो, योर lateral malleolus can go, your posterior malleolus will go. Okay beta, lateral malleolus can go, medial malleolus can go, posterior malleolus can go, and of course tibiofibular syndesmosis. ठीक है, ओके, tibiofibular syndesmosis, ये चारों में से कुछ तो जाएगा. फॉर एग्जाम्पल अगर मान लो मीडियल मेल्यूलस गया, तो फिर हम लोग को चेक करना है कि ये इसका कौन सा फ्रैक्चर है ना. आइदर, अच्छा, अब वो तीनों में, मतलब मेरे कहने का मतलब है कि वो मीडियल मेल्यूलस, लैटरल मेल्यूलस किसी का भी होगा, तो वो यही 3 फ्रैक्चर होंगे: ऑब्लिक फ्रैक्चर, एवल्जन फ्रैक्चर, ट्रांसवर्स फ्रैक्चर. ठीक है, सिमिलरली लैटरल के भी ऑब्लिक फ्रैक्चर, एवल्जन फ्रैक्चर, ट्रांसवर्स फ्रैक्चर. ठीक है, यही 3 फ्रैक्चर हो सकते हैं. So what you're supposed to do when it's a medial malleolus fracture, so just remember, if it is a medial malleolus fracture, transverse fracture, then you have to do the compression. ठीक है, then आप क्या करेंगे, इसमें आप क्या करेंगे, compression screw लगाएंगे, और क्या कर सकते हो, tension band wiring. Okay, tension band wiring is something you can do. ठीक है, so हम लोग बोलते हैं ना, if it's a transverse fracture, just take care. Okay, just take care. So take care is a mnemonic There T for tension band wiring and C for compression. ठीक है, T for compression screws can be used. ऑब्लिक में क्या करोगे, तो देखो ये O है, इसको कट कर दो, ये O से क्या बन गया, C बन गया, C मतलब क्या, compression screws. ठीक है, compression screws. What about eversion fracture? So eversion fracture में हम लोग क्या करते हैं, टेक केयर, और यू कैन रिमेम्बर कैट भी याद कर सकते हो आप लोग वैसे. Cat also is a good mnemonic to remember. Why? Because in avulsion fracture also you do T wala, T for tension band wiring. Okay, you do T wala, that is tension band wiring. Okay, tension band wiring. Similarly, if we go for the lateral malleolus and it's a transverse fracture, then what we will do? We will do T say T, T say tension band wiring. Okay, tension band wiring is something which we have to perform. And if it's an avulsion fracture, just understand, okay, इसमें ये नहीं होता है avulsion and oblique, इसमें क्या था, ट्रांसवर्स था, हाँ, स्पाइरल फ्रैक्चर हो सकता है. ओके, स्पाइरल फ्रैक्चर कैन अकर. व्हाट एल्स कैन अकर, कम्युनिटेड फ्रैक्चर कैन अकर. ठीक है, ये आपको याद रखना है. ओके, एंड समटाइम्स वी हैव सीन दैट सम फ्रैक्चर अकर्स इन द लोअर वन थर्ड ऑफ फिबुला. ठीक है, लोअर वन थर्ड ऑफ फिबुला. ठीक है, तो ये सारी चीजों में आपको क्या करना है. सो इफ इट्स अ लोअर वन थर्ड ऑफ फिबुला, सो रिमेंबर 3 के बाद क्या आता है, 4. सो यू हैव टू डू 4 प्लेट और 4 होल प्लेट करते हैं हम लोग. ठीक है, 4 होल प्लेटिंग कर देते हैं इसमें, 4 होल प्लेट. इफ इट्स अ स्पाइरल फ्रैक्चर, डू दी स्क्रूज. ठीक है, कौन से स्क्रू, एस स्क्रू, एस स्पाइरल फ्रैक्चर, कंप्रेशन स्क्रूज इज समथिंग विच यू हैव टू पुट. ओके, एंड ट्रांसफर्स मैंने बता दिया. कम्युनिटेड के अंदर में, यस, कम्युनिटेड में क्या करोगे, सो दिस इज सी, दिस इज, और सी के पास में क्या आता है, बी. बी फॉर व्हाट, बी फॉर बटरस प्लेट. ठीक है, बी से हम लोग क्या याद रखना, आप लोग को बटरस प्लेट करते हैं, बटरस प्लेटिंग. ठीक है, कमिंग ऑन टू द पोस्टीरियर मेलियोलस. सो जस्ट रिमेंबर कि पोस्टीरियर मेलियोलस में कितना आर्टिकुलर, सो पोस्टीरियर मेलियोलस जो होता है वो बेसिकली आर्टिकुलर सरफेस को जो है अपने साथ में ले लेता है. सो वी हैव टू चेक हाउ मच आर्टिकुलर सरफेस ऑफ टिबिया इज इन्वॉल्व. So if it is like less than one third is involved or more than one third is involved. Okay, if less than one third of tibia is involved or more than one third of tibia is involved, so if it is less than one third of articular surface of tibia is involved, then we will uh, require no additional treatment. ठीक है, कोई ज्यादा additional treatment हमें नहीं चाहिए होता. No additional treatment is required. But remember, if it is more than one third, then we have to do what, we have to put the compression screws. ठीक है, we have to put what, compression screws has to be given. ठीक है, and tibular fibular syndesmosis तो होता क्या है, suppose this is tibia, this is fibula, this was a syndesmosis. अब अगर ये चला गया, so what we'll do, we'll put a nail or screw. So what we'll put, we will put a long screw. S for syndesmosis, S for screw, long screw from the fibula to tibia, from the fibula to the tibia. ठीक है, so this is the internal fixation. Can we do external fixation? Yes, external fixation can be done. Okay, external fixation can be done. So when will we use the external fixation? Now for example, if there is compression, understand, if there is compression or if there is fracture of rather muscles and tendon. Okay, if the, not fracture, if the muscles and tendons are compressed, then in that case we have to use this. All right, so coming on to the last part where we discuss every time complications. So what are the complications of this, complications of Pott's fracture? Complications, one important complication is stiffness of ankle joint. Okay, so one important complication is stiffness of ankle joint. Okay, and the other important complication is going to be osteoarthritis. Okay, it is going to be osteoarthritis. So these are again important. This is all about the topic of Pott's fracture. So we have discussed Pott's fracture, we have discussed the posterior dislocation of hip as well. Coming on to the big topic, last big topic of today's class, and that big topic is, Hanji, what is this big topic? This is your coxa vera. ठीक है. So coxa vara. ठीक है. चलो. अच्छा, quickly tell me in the comment section if you guys can continue with the session, and coxa vara by 8:30 we will finish. बाकी के topics भी by 9 o'clock we'll finish, or you guys need a break of like 5-10 minutes. हाँ जी, बताओ जी जल्दी से, so that I can start the discussion accordingly. It's fine. Okay, okay, okay. ठीक है बेटा. So let's discuss about the coxa vara, and in coxa vara what is important. So remember, whenever there is injury to the growth plate of the head of the femur, okay, so you have got head of the femur, and whenever there is injury to what, to the growth plate, okay, whenever there is injury to the growth plate of the head of the femur, what happens is that the greater trochanter is going to grow, and greater trochanter it's going to grow, ठीक है, and head and neck are going to stop growing. Understand this, that head and neck can't grow, okay, head and neck stop growing, but greater trochanter is growing, and since the greater trochanter is growing and head and neck are stuck, this leads to coxa vara. Now, what do you mean by coxa vara? I have told you that, for example, if this is a hip joint, this is going to be the femur normally, okay, and in coxa vara, what is going to happen? There will be inward uh, rotation of your femur. Okay, there will be inward rotation of your femur. Okay, so what is important in this is that what are the types of coxa vara? So just remember that coxa vara, okay, the coxa vara type, or I should say that coxa vara can occur. Why it can occur? So coxa vara can be either uh, infantile, primary. Okay, so either it is going to be infantile, that we also call it as primary coxa vara, or this coxa vara can be acquired or secondary. Okay, or this coxa vara can be acquired coxa vara or secondary coxa vara. Okay, acquired coxa vara or secondary coxa vara can be associated with Perthes disease, can be associated with SCFE. So these are really important. Coming on to the clinical features now. Okay, clinical features. What are the clinical features which we see in coxa vara? So one, of course, I have already told you that there will be what, because the limb is moving a little bit inward. So if you will, you know, तो जो size रहेगा, length रहेगी, that will be less. So there will be one thing, that is limb shortening. Okay, there is going to be one thing that is called as limb shortening. Okay. Then second thing is that there will be failure of abduction. Understand, there will be failure of abduction. Abduct तो कर ही नहीं पाओगे, so there is failure of abduction. And you know very well, like if there is a failure of abduction, the gait will be Trendelenburg gait. ठीक है, कौन सा gait हो जाएगा? There will be Trendelenburg gait that is going to be there. There will be Trendelenburg gait. Why? Because there is failure of abduction. So because of failure of abduction, there is going to be Trendelenburg gait that is going to occur. Okay. Then limitation of abduction, of course I have told you, and similarly there will be limitation of internal rotation also, limitation of internal rotation also. So there will be no internal rotation, there will be no abduction. That is why what is going to happen, there will be obligate external rotation. there will be obligate external rotation that is going to occur. Obligate external rotation. ओके, ना तो लिम्ब बाहर जाएगा और ना ही अंदर की तरफ जो है वो रोटेट हो पाएगा, ना ही अंदर की तरफ रोटेट हो पाएगा और ना ही जो लिम्ब है वो बाहर जाएगा. ठीक है, समझ में आ गया. ऑब्लिगेट एक्सटर्नल रोटेशन, दैट मीन्स whenever you will flex the hip, okay, whenever hip is flexed, it is going to show external rotation. Okay, knee is going to go out whenever you are going to do the flexion. Okay, whenever you are going to do what? Whenever you are going to do flexion. So good question or important question here is, just understand what I have tried to tell you, that okay, we'll discuss about the congenital one sabse pehle. So if I discuss about the congenital coxa vara, okay, if I discuss about the congenital coxa vara, what is important in this is that there is a damage to the, damage to what? Damage to the which part? Damage to the Fairbank triangle. So there is a Fairbank triangle which is actually damaged. Now what does this mean? What does this mean? Just understand. For example, this is your femur. Okay, this is a part of Fairbank triangle, and here you will have your the head part. Okay, the trochanter part. So this is damaged. There is a damage to the this part. This is called as Fairbank triangle. There is damage to what? There is damage to the Fairbank triangle. Okay, so what is Fairbank triangle? This is actually a part of neck of, okay, part of neck of femur. Okay, the part of neck of femur. Okay, so that's important. Now, one question on your way. So the people who are watching us, okay, just tell me, where will you see Babcock's triangle? Where will you see Babcock's triangle? हाँ जी, Babcock's triangle कहाँ दिखता है बच्चे? Babcock's triangle is seen in, देखो, B Babcock's, T triangle, T B, T for tube, B for tuberculosis. Okay, tuberculosis. Okay, tuberculosis, right? So this is how you have to remember. So this was a little information about congenital coxa vara. But if they are asking you about the coxa vara as a full question or something, so just write a little bit about SCFE, and also mention some things about Perthes. So of course, Perthes and SCFE, both of them are really important topics. So what I'll do, I will just try to tell you these topics, SCFE and Perthes, in a little कैसे बताऊंगा मैं आपको, इसको differentiate करके बताता हूँ about the SCFE and the Perthes disease. Let me just tell you about SCFE and Perthes disease. ठीक है, Perthes disease, SCFE. So what is SCFE? Full form of SCFE is slipped capital femoral epiphysis. Slipped capital femoral epiphysis. Okay, slipped capital femoral epiphysis. Okay, so basically, Ram, if you look, so what they want to tell you, that slipped capital, slipped matlab slipping, moving. Capital means head. Okay, so moving head. Okay, but what you have to understand, that this is a misnomer. Okay, misnomer. Why? Because the head of femur is not moving out of acetabulum. Head of femur is not moving out of acetabulum. Okay, head of femur is not moving out of acetabulum, whereas it is the neck of femur that is going displaced. Okay, it is the neck of a femur that is going to, yes, Hanji, it is the neck of femur that is going to slip. Okay, that is going to slip. Okay, coming on to the pathogenesis. Okay, now coming on to the pathogenesis. So what is important in the pathogenesis of SCFE? Just remember one important thing, that there is a fracture of the growth plate. Okay, there is a fracture of growth plate. And since there is a fracture of the growth plate, there is going to be, the head and neck are going to be disrupted. Okay, the head and neck are going to be disrupted. Okay, the head and the neck are going to be disrupted, and since the head and neck are disrupted, remember in this case the head is still. Okay, head remains in the acetabulum. Okay, head is going to remain in acetabulum, whereas what is going to happen, the neck is going to slip. Okay, the neck is going to slip. Okay, the neck is going to what, neck is going to slip. Okay, so what can happen, just remember these two three things which you have to understand is, see, say for example this is the head and this is the neck. Okay, so what is going to happen, the head is going to be there inside the acetabulum, whereas the neck is going to slip. Okay, sometimes what happens is this is the slippage a little more. Okay, the slippage is little more, and sometimes the slippage is even severe. Okay, slippage is even severe. Okay, the slippage is even severe. Okay, so this is really very severe, right? So this is something you have to understand, either mild or the moderate, or there is going to be severe. So why there is a slippage, why does this happen? So that depends upon the etiology, and if you ask me the etiology, the most common one is going to be idiopathic. Okay, the idiopathic cause is the most common cause, really. Okay, and yes, one thing which we have seen is that it is associated with some endocrinopathies. Okay, associated with some endocrinopathies. And what are these endocrinopathies? Number one is going to be sex hormone problem or growth hormone problem. Okay, rather, I should say that it is a sex hormone to growth hormone issue. It is a sex hormone to growth hormone ratio problem. Why? See, sex hormone is responsible for bone fusion and growth hormone is responsible for bone growth. Okay, so if this balance is not maintained, then of course the growth will be hampered, the fusion will be hampered. Okay, and in this, the most common problem, the most common, if you ask, the most common endocrine issue is nothing else but your hypothyroidism, hypogonadism. Okay, hypothyroidism, hypogonadism. Okay, so the sex hormones will be less. Okay, so growth is going to be too much, or if the growth hormone is too much, the growth is going to be too much. Okay, coming on to the risk factors. So risk factors is, we have seen that the male population is more at risk than the female population. And for example, if they give you the history of more weight during childhood, okay, more weight, if they give you the history, okay, more weight for age or more weight during childhood, this is a very high risk factor for slipped capital femoral epiphysis. And it is mostly, what I should say, it is seen bilaterally only. Okay, most commonly bilaterally. So what was going to be the clinical feature? All the features of the endocrinopathies. Okay, like first of all, you should understand that it's going to present at puberty. Okay, so puberty, yes, and then you will have the features like hypogonadism. You will have the features of gynecomastia, the voice change. Okay, gynecomastia is going to be there, the voice change is going to be there. Okay, and yes, of course, the coxa vera feature is going to be there for sure. Okay, coxa vera is going to be there for sure. Okay, so one sign is very important when it comes to X-ray, and that sign is called as Trethovan sign. So what is this Trethovan sign? Let me just teach you Trethovan sign. Okay, so you have got. I have I have taken the X-ray of SCFE. Just 1 second. हाँ जी, चलो ये देखो अब इसमें क्या है. So you draw a line. Okay, you draw a line. So where are you going to draw this line? There is a line which is drawn on the lateral aspect of the neck of the femur. Okay, and that line is not going to intersect with the, like for example, see here, this is the head. Okay, this is the head, and if I draw a line on the lateral aspect of the neck of the femur, okay, this is called as Kleins line. Okay, this is called as cleans line. So what is cleans line? A line drawn on lateral aspect of neck of femur fracture. ठीक है, neck of femur. This is called as clean line, and cleans line does not intersect if it does not intersect with the head of femur. If it does not intersect with the head of the femur, then we call it as what? Then we call it as SCFE. Okay, slipped capital femoral epiphysis. This is called as SCFE. Oh, sorry, this is called as Strithoven sign. Okay, this is called as Strithoven sign, and this Strithoven sign is something that is very much positive in SCFE. Okay, it is positive in where? It is positive in SCFE. Okay, so what you will do? You will do CIP. Okay, what is CIP? Now SCFE is itself giving you the hint that the management part is going to be okay. So SCFE is itself giving you the hint. क्या नाम है देखो? SCFE. Okay, so C से closed, so closed reduction. F से fixation, internal fixation. Closed reduction will be there, internal fixation will be there. Okay, and yeah, pinning is also something which is advised, and that's to which pinning? This is in situ pinning is something that is advised. Okay, so this is about the discussion of SCFE. Okay, this is about the discussion of SCFE, and similarly now we will discuss about the Perthes disease also. Okay, now we will discuss about the Perthes disease. So what is important in Perthes? How Perthes is important? So remember, Perthes, P for Perthes, P for plana. Okay, so Perthes is something that is called as coxa plana. Perthes is something that is called as coxa plana. Perthes को आप लोग क्या बुलाते हो? Perthes को you call it as coxa plana. ठीक है, so coxa plana, or it is also called as leg calf Perthes disease. Leg calves Perthes disease. ठीक है, so leg calves Perthes disease is something that we call to the Perthes disease. ठीक है, चलो. So what is it by definition? So by definition, if we talk about, जैसे हमने थोड़ा सा यहाँ पे भी discuss किया था, so by definition, Perthes disease is an idiopathic spontaneous. Okay, it is idiopathic. It is spontaneous osteonecrosis. Idiopathic spontaneous osteonecrosis. Okay, and in adults we call it as Chandler's disease. Okay, it is also called as Chandler's disease in adults. ठीक है, adults में आप इसको क्या बुलाते हो बेटा? इसको आप लोग बुलाते हो Chandler's disease in adults. Chandler's disease in adults. Okay, right? So this is really important. ठीक है, so इतना आपको जो है पता होना चाहिए. ठीक है, this is important. तो देखो अब इसमें ना आप समझो, एक बार थोड़ा समझो, यही पैथोजेनेसिस भी यही हो जाएगा इसका, कि फॉर एग्जांपल इफ दिस इज योर ठीक है, फॉर एग्जांपल इफ आई जस्ट ड्रॉ दिस बोन फॉर यू. ठीक है, तो अब इसमें आपको एक चीज समझनी है बेटा. एक तो होता है ये सप्लाई, इसको आप लोग बोलते हो फोवियोलर फ्लो. ठीक है, इसको आप लोग क्या बोलते हो? फोविया, एंड दिस इज कॉल्ड एज फोवियोलर फ्लो ऑफ ब्लड सप्लाई. ठीक है, फोवियोलर फ्लो ऑफ ब्लड सप्लाई. ठीक है, और एक होता है बच्चे जो यहाँ पर ब्लड वेसल्स होती हैं, इनको आप लोग बोलते हो मेटाफाइसियल फ्लो ऑफ ब्लड सप्लाई. ठीक है, उसको आप लोग क्या बोलते हो? उसको आप लोग बोलते हो मेटाफाइसियल फ्लो. ठीक है, इसको आप लोग क्या बोलते हो? मेटाफाइसियल फ्लो. तो होता क्या है बेसिकली, 4 to 10 ईयर्स की जो एज है, अच्छा अभी 4 साल तक, जैसे फोविया है तो यहाँ पे FOUR 4 याद रखो, और 4 याद रखो, 4 ईयर्स तक. सो 4 ईयर्स तक फोवियोलर जो होता है वो प्रेडोमिनेंटली यही सप्लाई होती है, वेर एज मेटाफाइसियल जो होगा बेटा वो 10 ईयर्स के आसपास में आता है. ठीक है, तो होता क्या है कि बिटवीन 4 to 10 ईयर्स, ठीक है, 4 से 10 साल की उम्र के बीच में होता क्या है, देयर इज हेड ऑफ, मतलब हेड ऑफ फीमर इज वेरी वल्नरेबल. ओके, हेड ऑफ फीमर इज वेरी वल्नरेबल, क्योंकि एक जगह से आर्टेरियल सप्लाई बंद हो रही होती है, दूसरी जगह पे शुरू हो रही होती है। सो हेड ऑफ फीमर इज वेरी वल्नरेबल। एंड इसी में ही इडियोपैथिकली कुछ कुछ इंडिविजुअल्स में हम लोगों ने देखा है दैट इट कैन इवन अंडरगो ऑस्टियोनेक्रोसिस, इट कैन इवन अंडरगो ऑस्टियोनेक्रोसिस। ठीक है, यानी कि नेक्रोसिस होने लग जाएगा, यानी कि डेड पार्ट आना जो है वो शुरू हो जाएगा। तो मैंने आपको जैसे कि बताया कि व्हाट इज द इटियोलॉजी, तो हम लोगों ने एक चीज तो हमने बहुत अच्छे से डिस्कस कर ली, दैट द मोस्ट कॉमन इटियोलॉजी is going to be what? That's going to be idiopathic. So one etiology is of course idiopathic. Other is remember protein S deficiency. It has been seen कि protein S deficiency यदि है, that means it's a thrombotic condition, thrombus बन जाएगा, और फिर वहां पर ऐसे केसेस में क्या होना बहुत आम बात है, ऑस्टियोनेक्रोसिस, क्योंकि ब्लड सप्लाई ही प्रॉपर नहीं है। मेल्स में ये ज्यादा देखा जाता है एज कम्पेयर टू फीमेल्स, एंड वी हैव सीन दैट क्या बोलते हैं, बाइलैटरल रहेगा, बट बाइलैटरल कम केसेस में रहता है, लाइक ओनली 10% केसेस आर बाइलैटरल। एंड रिमेंबर 6 years के आसपास में जो है इसमें उम्र होती है पेशेंट की। ठीक है, सो व्हाट कैन बी क्लिनिकल फीचर्स? देखो, इफ यू आस्क मी अबाउट द क्लिनिकल फीचर्स, जेन्युइनली टेलिंग यू, इफ यू आस्क मी अबाउट द क्लिनिकल फीचर्स, देखो अब अगर नेक्रोसिस हो रहा है कहीं पे भी, ठीक है, तो वहां पर पेनलेस रहेगा ये हिप पूरा। ठीक है, पेनलेस रहेगा, लिम्प रहेगा। लेटर ये पेनफुल भी हो सकता है। ठीक है, लेटर इट कैन बी painful also, but remember initially it is also painless. Okay, and once it is painful, it is going to radiate to the knee, it is going to radiate to the groin region. Okay, and remember abduction इसमें भी नहीं हो पाएगी, और internal rotation भी इसमें नहीं हो पाती। abduction नहीं हो पाती है, internal rotation नहीं हो पाती है, ये लोग obligate external rotators हैं, obligate external rotators होते हैं। ओके, एक्सटर्नल रोटेटर्स होते हैं। ठीक है, सो व्हाट इज द इन्वेस्टिगेशन, व्हाट यू विल डू ऑन द नेम ऑफ इन्वेस्टिगेशन? तो इन्वेस्टिगेशन के लिए बच्चे यहाँ पर आप लोगों को एमआरआई परफॉर्म करनी होती है, दैट इज द इन्वेस्टिगेशन ऑफ चॉइस। ओके, दैट इज द इन्वेस्टिगेशन ऑफ चॉइस। ठीक है, so what will you do as a part of treatment? So coming on to the last part, how will you manage the case? So see, the goal is to sustain the head till the vascularity returns. Okay, so मतलब क्या करो कि देखो, वैस्कुलैरिटी तो जब आएगी तब आएगी, तब तक आपने क्या करना है, हेड को बचा के रखना। ठीक है, सो लेस और नो वेट बियरिंग। ठीक है, वेट डालने की उसके ऊपर में ज्यादा जरूरत ही नहीं है। strictly we will do skin traction. Now what is skin traction and everything, of course I'm going to teach you, for sure I'm going to teach you। अभी के लिए इतना याद रखो। कास्ट अप्लाई करेंगे, कौन सी कास्ट होती है इनमें? पेट्री कास्ट आप लगा सकते हो, ब्रूमस्टिक कास्ट आप लगा सकते हो। ठीक है, पेट्री कास्ट, ब्रूमस्टिक कास्ट ये लगा सकते हो। एंड यस, टोटल हिप रिप्लेसमेंट आप कर सकते हो व्हेन after skeletally being mature। ठीक है, so once it is skeletally mature, then of course you can do the total hip replacement as well। ठीक है, उसके बाद आप लोग total hip replacement करने का सोच सकते हो, बिल्कुल सोच सकते हो। ठीक है, so this is the end of the coxa vara topic। ठीक है, coxa vara भी जो था हम लोगों ने पढ़ लिया है। ठीक है, तो coxa vara मैंने आपको पढ़ा दिया है, एक बार फटाफट से इनके जो है हम, अच्छा पॉट्स फ्रैक्चर तो बेटा एंकल का है, ये तो मैंने आप लोगों को पहले ही बता दिया। ठीक है, कि ये देखो यहाँ पे फिबुला डैमेज है। ओके, एंड दीज थिंग्स, पॉट्स फ्रैक्चर ये हो गया हमारा। परथीज, ठीक है, सो परथीज डिजीज, जस्ट रिमेम्बर परथीज में हो क्या रहा है, नेक्रोसिस दिख रहा है ना आप लोगों को, ये नेक क्या हो रखा है यहाँ पे, ऑस्टियो नेक्रोसिस हो गया है, ऑस्टियो नेक्रोसिस हो गया है। एंड दिस इज ऑल्सो नॉट वेरी, आप देखो ये स्केलेटन भी जो है वो पीडियाट्रिक स्केलेटल है, यानी कि छोटे बच्चों में है, पीडियाट्रिक स्केलेटल है। ठीक है, चलिए उसके बाद हाँ ये क्वेश्चन देख लीजिए अब। 13-year-old बॉय, देखो पहली बात ही मोर देन 10 years है, तो दिस इज नॉट गोइंग टू बी परथीज, दिस इज टेलिंग यू अबाउट दी SCFE। प्रेजेंस विद हिप पेन, पेन है, लिम्प है 2 weeks के लिए, कंप्लेन्स ऑफ पेन रेडिएटिंग टू थाई एंड नी। ठीक है, अब पेन जो है रेडिएट हो रहा है यहाँ पर, अब ये दूसरी चीज है, वो तो पेन किस में रेडिएट होता है, परथीज में होता है ना। ठीक है, नो हिस्ट्री ऑफ ट्रॉमा, दैट मीन्स ट्रॉमा की हिस्ट्री नहीं है। अफेक्टेड लिम्ब इज एक्सटर्नली रोटेटेड, यानी कि ये भी किसमें देखने को मिलता है हम लोग को, एक्सटर्नली रोटेटेड, परथीज में भी देखने को मिलता है। ऑब्लिगेट एक्सटर्नल रोटेशन अगेन परथीज में देखने को मिलती है। ठीक है, और लेकिन यहाँ क्या है, पोस्टेरो इंफीरियर डिस्प्लेसमेंट ऑफ द फेमोरल हेड रिलेटिव टू द नेक। ठीक है। अब देखो ये लोग आपको बता रहे हैं कि इन रिलेशन टू द नेक हमारा जो फेमोरल हेड है ना वो डिस्प्लेस किया हुआ है। इनका ये मतलब नहीं है कि इसमें हेड डिस्प्लेस करता है, बट जस्ट दे आर ट्राइंग टू टेल यू। सो दिस इज SCFE। ठीक है, SCFE। इस तरीके की हिंट्स अगर आपको बता रहे हैं तो ऑफ कोर्स दिस इज गोइंग टू बी SCFE, बिकॉज ये सारी चीजें उनमें भी देखने को मिल सकती हैं। पेन माइट रेडिएट टू थाई, नी, देयर कैन बी एक्सटर्नल रोटेटेड और एक्सटर्नल रोटेशन ऑल्सो। बट इफ इस तरीके की कुछ बात दे रखी है बच्चे तो फिर सीधी सी बात है कि दिस इज गोइंग टू बी SCFE। हाँ जी, दिस इज परथीस, बिल्कुल 7 ईयर ओल्ड, बिल्कुल सही बात है, परथीस रहेगा। लिम्प है 3 मंथ से, ठीक है, गुड। लिम्प इज पेनलेस इनिशियली, नाउ एसोसिएटेड विद पेन, बिल्कुल। क्लासिकल हिस्ट्री किसकी दे दी इन्होंने? परथीस की दे दी। कहां पर दे दी? हिप एंड नी, रेडिएटिंग पेन, अगेन परथीस। आई नो ये बंद हो गया था, सो आई जस्ट रिपीट दिस पार्ट। तो जहां इन्होंने लिखा है दैट देयर इज नो फीवर एंड no trauma, no fever, that means they are just trying to tell you that there is no fracture and no infection. And later they have told you that this is restricted abduction and internal rotation, that is again suggestive of Perthes. Trendelenburg test is positive, yes, of course. SCFE may be positive hai, Perthes may be positive hai, but if X-ray is telling you that it's flattening and fragmentation of the femoral head, that has to be Perthes disease. ठीक है, that has to be which disease बच्चे? That has to be Perthes disease. ठीक है, क्या होगा वो? Perthes होगा। ठीक है, चल, good. So now coming on to these parts, the Thomas splint, the traction. ठीक है, चलो ये अब हम लोग पढ़ लेते हैं। एंड आई थिंक इट्स 8 o'clock ओनली, 8:10। ठीक है, 8:12 हो गया है। सो नाउ ओनली द स्मॉल टॉपिक्स आर लेफ्ट। ठीक है, तो अभी हम लोगों को 3-4 टॉपिक्स डिस्कस करने हैं। सो पोस्ट ब्रेक वी विल डिस्कस अबाउट द थॉमस पार्ट, द थॉमस स्प्लिंट एंड द थॉमस टेस्ट। देन वी विल डिस्कस अबाउट द ट्रैक्शन। ओके, वी विल डिस्कस अबाउट ट्रैक्शन। और उसके बाद में इफ द टाइम परमिट्स वी विल गो फॉर AVN, avascular necrosis of head or femur. ठीक है, चलो we will meet on 8:22 p.m. Okay, just a small 10 minutes का break. Okay, 10 minutes small break. All right, students, I feel and I think I am perfectly audible to all of you. Yes. All right, students, I feel and I think I am perfectly audible. ठीक है जी, ठीक है, ठीक है. माइक का प्रॉब्लम है, चलो कोई बात नहीं. ट्रैक्शन, ठीक है. अब हम लोग डिस्कस करेंगे अबाउट द टॉपिक ऑफ ट्रैक्शन. ठीक, क्या होता है हिंदी में? ट्रैक्शन का मतलब होता है खिंचाव. ठीक है, ट्रैक्शन का क्या मतलब होता है? खिंचाव. एक्चुअल में ट्रैक्शन पे ऐसा जितना ज्यादा क्वेश्चन नहीं आता. क्वेश्चन ज्यादातर पूछा जाता है स्किन ट्रैक्शन पे. ठीक है, स्किन ट्रैक्शन. ठीक है, सो ट्रैक्शन में भी हम लोग ज्यादातर क्या डिस्कस करेंगे? अबाउट द स्किन ट्रैक्शन. ठीक है, चलो. सो बट coming on to traction. So what is traction? So let's write down the definition of traction. Traction means it's a mechanical force. ठीक है, लिखेंगे अब साथ साथ. It's a mechanical force applied against a resistance. Mechanical force applied against a resistance to overcome deforming forces. To overcome deforming forces. हाँ जी. So what is it? So remember that it is a. हाँ जी. So what is it? Just remember it's a mechanical force applied against a resistance to overcome the deforming forces on a pathological joint or a fractural fragment. This is really important line which you have to understand. ठीक है, कि हमें खिंचाव लगा रहे हैं उन फोर्सेस के अगेंस्ट जो कि किसी भी पैथोलॉजिकल जॉइंट को डिफॉर्म कर सकती हैं. ठीक है, तो आप लोगों को इसको याद रखना है. ठीक है, कि इट्स अ मैकेनिकल फोर्स अगेंस्ट रेजिस्टेंस टू ओवरकम द डिफॉर्मिंग फोर्सेस on a pathological joints or a fractural fragment. Fractural fragment. ठीक है, अच्छा. no, sorry. Now what is skin traction? ठीक है, स्किन ट्रैक्शन क्या है? स्किन ट्रैक्शन में आप जो फोर्स लगाते हो, सो सी अंडरस्टैंड व्हाट इज देयर. दिस इज स्किन ट्रैक्शन. ठीक है, so skin traction means where the tractional force, ठीक है, it's the tractional force applied over a region of tractional force applied over a region of over a large region or large area of skin. ठीक है, इसको हम लोग बोलेंगे स्किन ट्रैक्शन. ठीक है, अच्छा. अब स्किन ट्रैक्शन के अंदर में व्हाट आर द डिफरेंट एप्लीकेशंस? ठीक है, व्हाट आर द डिफरेंट एप्लीकेशंस? So applications of skin traction or applications of any traction for that matter. First application is to reduce the fracture. So we use the traction to reduce the fracture, and this reduction in fracture is responsible for promoting the healing. So in order to promote the healing, we reduce the fracture, and this fracture reduction is done by traction. Okay, then it is to reduce the dislocation in a joint. ठीक है, reduce the joint dislocation. ठीक है, जैसे हमने कोलीज फ्रैक्चर में पढ़ा था. ठीक है, फॉर एग्जांपल कोलीज फ्रैक्चर हम लोग ट्रैक्शन काउंटर ट्रैक्शन दे रहे थे. ठीक है, इसी तरीके से जॉइंट डिसलोकेशन में हम लोगों को यूज होता है. ठीक है, देन ट्रैक्शन कैन रिलीव द पेन ऑल्सो. ओके, तो आपने देखा होगा बहुत सारे क्रिकेटर्स वगैरह भी ऐसे एक ब्लू कलर के पैड को ऐसा लगा के रखते हैं ना, उससे क्या होता है, उससे जो पेन है वो कम हो जाता है. इट रिलीव्स द पेन. ठीक है, देन resting the limb in functional position. Resting the limb in functional position. ठीक है, functional position के अंदर में अगर आपको इसको रेस्ट करना है तो आप लोग इसको यूज कर सकते हो. ठीक है, then overcoming the muscle spasm. Overcoming the muscle spasm. And of course correcting the सॉफ्ट टिश्यू कॉन्ट्रैक्चर्स. ठीक है, अगर सॉफ्ट टिश्यू का कॉन्ट्रैक्चर हुआ है, फाइब्रोसिस में वो गया, तो उसको भी ठीक करने के लिए हम लोग क्या कर सकते हैं? स्किन ट्रैक्शन का सहारा ले सकते हैं. Skin traction. What are the different types of skin traction? So one is the adhesive skin traction, other is नॉन एडहेसिव, ठीक है। तो एक होता है एडहेसिव स्किन ट्रैक्शन देते हैं, दूसरा होता है नॉन एडहेसिव स्किन ट्रैक्शन देते हैं, ठीक है। So skin traction where the traction force is applied over a larger area of the skin. ठीक है. Now what is the method to apply this? Okay, so method is simple. So traction is applied over a area of skin. ठीक है. Over a large area of skin, we are going to apply the traction. Okay, and then what is going to done? See, load is spared. Okay, a load is going to be spared, and this load which is spared is going to increase the comfort and increase the efficiency also. Okay, so it is going to increase the comfort, it is going to increase the efficiency also. Okay, so certain characteristics. Okay, how much weight should be given? It should be 1/10 of the body weight, like 1/10 of the body weight. For example, a 70 kg man, so approximately 7 kgs body weight you can do. Okay, right? Acha. Next, if you are using adhesive, if you are using, which adhesive you are going to use? Zdeno. Okay, zinc oxide is used, acrylic is something that is used. Okay, so these are the adhesives which are used. Then what are the contraindications of skin traction? So contraindication is where there are abrasions or some other injuries like lacerations. There you refrain to use the traction. Dermatitis, okay, if adhesive dermatitis like that. If the skin is fragile and post burns patient, the skin is fragile, especially superficial burns patient, the skin is going to be fragile. Okay, or if there is impending gangrene, because once you stretch, the vessels are also going to get stretched, so the gangrene is going to be worsened. Okay, so these things are really important. Skin traction, and then we have got the skin traction I have told you in detail. Okay, right? Chalo. Coming on to the next topic now. तो traction हमने पढ़ लिया, एक traction का short note prepare कर लिया. Now coming on to Thomas splint or Thomas traction splint. Okay, so Thomas traction splint, our next topic of discussion. Okay, so Thomas traction splint. Okay, so let me just introduce you to the topic. Hanji, introduction of the topic. So Thomas traction splint is called this because it was designed by Hugh Thomas. Hugh Thomas or Hugh Thomas. Yes, Thomas. Okay, so why it was Hugh Thomas was the one who designed this. Okay, designed for it was designed for actually tuberculosis. So it was designed T for Thomas, T for tuberculosis. So TB of knee के लिए जो है इसको डिजाइन किया गया था. Okay, and later it was used in World War. Okay, later it was used in World War by Robert Jones. Okay, to do the stabilization. Now this was the introduction. Coming on to what are the different components of Thomas splint. Okay, what are the different components of Thomas splint? So see, this is the ring. Okay, this is the ring part, and then you have ठीक है. तो देखो इसमें इस सबको क्या बोलते हैं? This is called as ring. This is called as inner bar. This is called as outer bar. Inner bar, outer bar, ring. Okay, and some dimensions are also important. How much should be the outer bar? It should be approximately 6 to 9 inches. Okay, then how much should be your or this distance is 6 to 9. Okay, the feet to this one, 6 to 9 inches gap. Okay, this is the feet. Then how much should be the angle? 120-degree. How much should be the slope? 5 centimeters. Okay, so again this is important. Okay, and this ring is generally well padded. Okay, so we do a cotton pad and stuff. So well padded circular ring, outer bar with this angulation, and inner bar, and this is called as W-shaped joint. Okay, W-shaped joint of two bars. Okay, W-shaped joint of two bars, really important. Okay, Coming on to certain measurements now. Okay, so I've actually told you some measurements in the diagram itself. Coming on to the other measurements now. So other measurements, remember the length that should be crotch to heel. Okay, crotch to heel, I've told you that should be approximately 6 to 9 inches. Okay, circumference, yes, how much should be the circumference of the ring? Yes. So how much should be the circumference of the ring? Circumference, remember, it is taken below the gluteal fold and ischial tuberosity. Okay. Taken below gluteal fold and ischial tuberosity. Okay. So you have to understand now that you have to take it below the gluteal fold and ischial tuberosity. So if it is a normal thigh, then just add 2 centimeters. Okay. So normal thigh, so what you have to do, the circumference of oblique circumference of thigh plus 2 inches. That is going to be for normal thigh. But for example, if the thigh is affected, okay, if it is a affected thigh, then in that case, oblique circumference equal to circumference of padded ring. Okay, equal to circumference of padded ring. Okay, equal to circumference of padded ring. Okay, right? So this is the measurement part. Now, okay, समझ में आ गया? Great, 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 great. So now, how do you wrap this? Coming on to the next part, how is wrapping done? Okay, so you have got a so there are two bars, right? So if I just try to show you a little picture of it, so there are two bars. Okay, so you will do a sling wrapping. Okay, you will do what? You will do a sling wrapping. Okay, so a sling is wrapped between the sidebars. A sling is wrapped between the sidebars in a U-shaped manner. Okay, in a U-shaped manner. Okay, in a U-shaped manner with a with what? With a roller bandage. So how do? We take a roller bandage and do this. Okay, on which the limb can rest. On which the limb can rest. Okay, right? So this is important and you have to understand. Okay, and then we put a master pad of Henry. Now, what is this master pad of Henry? So master pad of Henry is actually a roll, okay, a roll which is put under thigh to give anterolateral to give anterolateral angulation anterolateral angulation of femur. Okay, anterolateral angulation of femur. Okay, and then okay, yeah, so this is about wrapping. Coming on to the uses. So where are you using it? So first use is for the transportation. So in the transportation, where transportation? For example, there is a femur fracture. For example, there is a subtrochanteric fracture. So in these cases, to transport, we use this. Okay, then if some surgery is awaited, okay, for example, we know that this patient needs surgery, but for some time we have to keep the patient, to stabilize the parameters. Okay, so if you are waiting for parameter stabilization. Okay, waiting for what? Waiting for parameter stabilization. So in that cases we have to do this. Okay, then for example, one important thing, for example, if there is a pediatric shaft fracture, if there is a shaft fracture, or pediatric femur shaft, not fracture I should say, but for example, if we want to give their traction, sliding traction, fixed traction, in those cases we use. Okay, sliding traction or fixed traction, if you want to give to a pediatric patient, we use it there. Okay, last but not the least, complications. Yes, it is responsible for causing skin abrasions, and it is also responsible for causing neurovascular complications if too much tight. So if it's too much tight, then of course neurovascular complications can occur. Okay, now just for your viva purpose, sometimes some examiners ask you to identify this, and once you identify this, they'll ask you what are the other splints. Okay, any other splints. So why they ask, because they think that the normal one which we used on the cervical region, so cervical hard collar, that's also a splint itself. Okay, and one more which you can remember is Philadelphia collar. Okay, Philadelphia collar. So these are the important things you have to understand, learn, and retain. Thomas traction splint. Okay, Thomas traction splint. Okay, coming on to the next part, the last part of today's class, and that is your, see, MCQs I planned to take, but yeah, we are running a little late, so I can take an extra class, so maybe to cover the MCQs, right? But abhi ke liye, for now, we will discuss the last part, and that is the Thomas test. Okay, Thomas test. Not much, many universities are fond of asking this question, but yeah, Thomas test was asked in one of the other universities in, I think, in Maharashtra or somewhere. So that's why my duty is to teach you that also. So we'll discuss about the Thomas test. Okay, Thomas test now. So, so why do we do Thomas test? Because sometimes what happens is, see, let me just try and explain you. For example, this is the limb of the patient. Okay, and the patient is here. Okay, so okay, so this part is the lumbar lordosis. Okay, this part is the lumbar lordosis, and whenever you want to check the flexion deformity, whenever you want to check the flexion deformity, this lumbar lordosis is not allowing you to do that. So the aim of this test, aim of this what I should say, aim of this Thomas test is to remove, aim is to remove lumbar lordosis, aim is to remove lumbar lordosis, so that, or I should say compensatory lumbar lordosis, so that flexion deformity, so that flexion deformity becomes obvious and can be measured. ठीक है, ताकि हम उसको देख पाए और फिर उसके बाद वो मेजर हो पाए. बिकॉज व्हाट, देखो, अगर ये लॉर्डोसिस नहीं जाएगा, ठीक है, तो हमें फ्लेक्शन नहीं दिखेगी. एक बार ये नीचे आ गया, तब जितना भी ये ऊपर उठा होगा, फ्लेक्स हुआ होगा, हम लोगों को पता लग जाएगा. ठीक है, हम लोगों को ये पता लग जाएगा. ठीक है, सो राइट, सो नाउ द पेशेंट इज आस्क्ड टू लाई सुपाइन ऑन अ हार्ड सरफेस. ठीक है, हाउ टू डू? तो ask the patient to lie supine on hard surface. Okay, the patient will be lying supine on the hard surface, and then what? 1 second, guys. Yeah, this is important, beta. इसीलिए तो that is why only I'm teaching now, because it's important. Okay, so supine on the hard surface, and then what you do, you flex the normal hip of the patient. Okay, you flex the normal hip of the patient, and once you flex the normal hip of the patient, the lumbar lordosis is going to, lumbar lordosis will be gone. Okay, and then you can see the flexion deformity, see the flexion deformity. Okay, and how will you feel that? Because you place one hand over here. Okay, so one hand is actually placed over here. So once this lumbar lordosis is gone, you can be it, you can feel that. Okay, so this is again important. Okay, and then what is going to happen? So what you do, the flexion deformity is now visible. So flexion deformity, because it is now visible, so the angle between the flexion deformity, understand, the angle between the flexion deformity and the angle between, hanji, angle between the flexion deformity and the bed, okay, is something that is calculated to know how much is the flexion deformity. Okay, okay, हाँ, ठीक है, चलो, तो वो आप लोगों को जो है वो पता होना चाहिए. दिस इज समथिंग दैट इज रियली रियली इम्पोर्टेंट. ठीक है, चलो. अच्छा, एक कहीं थोड़ा बहुत जिक्र इस बात का भी है, व्हाट आर द प्रॉब्लम्स when we perform the Thomas test. So which problems are not very much like, in females sometimes it becomes a little proper exposure problem, right? And then in fatty patients also it is difficult to be performed. Okay, so, and the third thing, if the flexion deformity is bilateral, then it is difficult to be performed. Okay, flexion deformity is bilateral, then also we can't perform it. Okay, and then painful hips also. Okay, painful hip region, then also it is difficult to be performed. So this is actually it of today's class. Now I know two topics are remaining. One is avascular necrosis of neck of the head of the femur, and the other important part is your MCQs. So either in the next class or surely I'll complete these both topics as well. Okay. So thank you so much for joining today's session, and I am very very grateful to all my dear students for attending this. We will see you tomorrow, and tomorrow अगर किसी की नजर नहीं लगती विद ड्यू, नहीं लगेगी, नहीं लगेगी, किसी की नजर नहीं लगेगी. सो वील स्टार्ट एट 4 PM शार्प इन द इवनिंग. ओके, 4 बजे फिर हम लोग स्टार्ट कर देंगे. ठीक है, चलो, गॉड ब्लेस यू, वी विल मीट टुमारो देन.